excited to have you all join us today. This weekend, it's all about fertility and endometriosis. And before I introduce you to our incredible doctors and specialists, I want to tell you why Patient Day matters to me. Because I'm a patient. I am 1 in 10, and I am also one of the women and individuals born with a uterus who was diagnosed with infertility at only 33 years old. And it was crushing. And I didn't know where to go. There wasn't a lot out there. A lot of people suffered in silence. With 2 diagnoses at the same time, I learned at 33 years old that I had endometriosis and infertility. The first thing I did was Google, right? That's what we all do. We Google, we look for answers, we look for support anywhere, social media. And the first thing that popped up was EndoFound, endofound.org, where I learned the symptoms of the illness, where I learned that endometriosis is one of the leading causes of infertility. And I found a bit of solace in that. I realized that I wasn't the only one suffering with this, and that there was a place that I could go to find knowledge, which is power, and to find support. It was then during that diagnosis that I thought, what can I do to help? How can I take what has been one of the most trying times in my life and do something to at least make a small ripple effect? And that's when I got involved with EndoFound. EndoFound was co-founded by Dr. Tamar Sechkin, who has devoted his life to this disease, this insidious disease that has taken so much from so many people, not just the individual themselves, their partners, their loved ones. It's taken their quality of life, their dreams, and it shouldn't. But Dr. Tamar Sechkin has once again committed himself to helping those that suffer with this illness. And it is my privilege to be here to introduce you to Dr. Sechkin, who is going to discuss a bit about fertility and endometriosis, along with surgeon, excision specialist, and also an endo patient herself, Dr. Carly Goldstein. Dr. Tamar Sechkin, the floor is yours.
Thank you. I hope I am connected to all of you. You're hearing me and seeing me. I'm in New York, Brooklyn, and connecting, hoping that everybody who registered is online. We have close to 1,300 individuals registered. We're proud to announce that. That's very exciting. Overall, this is an exciting and ambitious program we initiated. This is our 13th year doing this, but we never did 4 weeks in a row in segments. We thought we could reach more and educate more at the comfort zone of people's home, Sunday mornings. What else to be done? It could be nice. You could be in your pajamas and watching certain things and pay attention better. So we're starting with the infertility session, but overall, in the end, it's about creating awareness, and awareness is hand in hand with education, and when that patient autonomy kicks in, patient makes a decision for themselves. If it wasn't the patients, we would never be here. It's the patients who are looking for their best interests, and we are informing them to find the right path. And in fertility world, endometriosis is seriously neglected. As you all know, that's why we're trying to create this. 1 in 10 women is affected with endometriosis, and 1 in 10 women is affected by infertility. And 50% of those women with infertility have definitely endometriosis, and most of them are known to have endometriosis because fertility doctors find endometrioma. Unfortunately, my fertility colleagues really don't care about patients' symptoms much. All of these patients, according to the fertility index versus endometriosis index, they all have significant dysmenorrhea, in other words, painful periods, heavy bleeding, pelvic pain, most of their catchphrase maybe you can catch in this meeting is their endo usually gets flared up by stimulation. That's a key. Interesting that you should all know. So before going so far ahead, after this program of infertility, there will be three other. One is going to be peritoneal endometriosis. The other will be deep debilitating at our medical conference. I really wish you enjoy and be educated and ask questions in the end. Again, I'm very happy to be here with you. I'm going to introduce my colleague, endometriosis surgeon specialist that has been working with me over 7 years now, maybe more. A gifted surgeon and very compassionate individual, Dr. Carly Goldstein.
Join us for our patient conference. Inspire, engage, and build a community supporting each other. That is what we're here to do for the Endometriosis Foundation of America's patient conference. The EndoFound lobby offers a state-of-the-art virtual experience, complete with interactive features that help you connect with other endo warriors, learn about the disease, and share your experience with endometriosis. You've told us you wanted a more interactive experience, and we listened to you. You're seeking community, and you want to learn from one another. You want to build support, and you want and deserve your questions answered by professionals. Our platform is easy to use, even for someone like me who's not tech savvy. On the left, you can enter the lobby for networking. Once you enter the lobby, you can navigate the different conversations by moving your icon to the discussion room. If you want to speak with someone individually, move your icon over to them, and the system automatically creates a private conversation. You can even lock your conversation so no others can join. If you need any help navigating, you can visit the help room in the lobby, and an EndoFound staff member will be there to assist you. In addition, you can watch live broadcast of our weekend symposium. The 13th annual medical symposium and patient day will provide you all the tools and information you need to live your best life with endometriosis. We are bringing together leading endometriosis professionals and experts to discuss cutting-edge endometriosis research, treatments, and advances in diagnosis and treatment. We're delighted to host not one, but 3 days of empowering and educational events during March Endometriosis Awareness Month. Please make sure to review the chat rules. Remember, we always respect our friends and colleagues. Differing opinions are of course okay, but we aim to foster a safe, supportive, and inclusive environment for everyone who's here for the conference.
Good morning. Welcome. First of all, we're so excited to have you here in March for our Endometriosis Awareness Month. And as we kick off this month, it is a very special day for me to introduce to you. Today is our day on endometriosis, infertility, fertility, and all kinds of planning that could involve your interests. And so we made this day for you, and thank you for coming. We really appreciate it. March is Endometriosis Awareness Month, and later in April will be more Infertility Month, but we wanted to group these two together with some of our dear colleagues that have come and shown up on a Sunday to help us. So thank you so much, everyone. It is a topic that is my passion. I'm a surgeon at Sechkin Endometriosis Center and Lenox Hill Hospital in New York, and this focus for me is a huge topic due to what I went through as a patient. And so I'll briefly tell you that so that we can get into patient day here, and I'll put my patient day hat on for you guys. Today, we hope to also answer a lot of the questions you have and dive deeper into some hot topics that are in constant flux in the fertility world. And we're excited to be here with a brilliant group of fertility specialists, lovely patients, support therapists, all kinds of people that could hopefully help you as well. I will briefly tell you that I was a fertility patient too, and currently still am in some sense. And I do believe that if we talk more about what we go through with each other, our friends, our family, and our colleagues, it would actually help more patients and more women, men, anyone going through transgender, anyone going through this condition around the world. How refreshing it would be when you tell someone you're going through IVF or the struggles you've been through, and instead they ask you, when is baby number 2 coming? Instead of saying all of these questions to you, why don't they say, I hear you, or I went through that too, and we struggled as well? That would be really nice. But unfortunately, it's something that not a lot of people talk about. Instead, most people bear this stress in silence. No one talks in the waiting room and fertility offices that I've been to, and I've been to several. They don't tell their family and friends what they're going through. They're on tons of medications, injections, stressed out, waking up, hearing terrible news, and 5 a.m. going to monitoring appointments and having multiple losses, and people aren't really talking about it. And why? There's still a stigma about this, even though the media and news likes to release stories about 50 to 52-year-old women who get pregnant successfully and have their own baby and baby on their own at 50, 52, not telling the public actually how they did it, which was with donor egg or eggs they froze 10 years earlier. I wish that there was a more realistic view that we can give patients across the world for what infertility is and all of the different processes of it. And so that's a little bit of what we're trying to do today, realizing it's a huge nutshell to try to cover in 4 hours or 3 hours. So my story is, when I was 17, I was told by a gynecologist my uterus was tilted backwards and I would actually never have a baby and I would never be able to get pregnant. I left the office in tears and I never wanted to go back to gynecologists. Funny that I did become one day. And, I spent much of my 20s wondering if that was true and being upset about that and trying to be open-minded, but still having this kind of lull fear on the back of my mind. Egg freezing at that time was expensive and the outcome wasn't perfect. And it was sort of a thing they tried to get college kids to do to make some money on the side. I sat through a lot of my 20s just kind of waiting for things to happen, always being a babysitter around kids and always wanting them in my life, but not knowing if that would ever happen for me. My endometriosis journey, a lot of it was really caught up in irritable bowel disease and Crohn's diagnosis and things like this. And it wasn't until I was actually an OBGYN resident that I was checking my fertility hormone levels. It was popular to do that in residency when you were on the REI rotation. And I found out that my ovarian hormones were actually terrible. They were the level of someone that was in their 40s, and I was 30 at the time, or 31. So this put me in sort of a tailspin of trying to do the right things quickly, freeze eggs, go through residency at the same time, and try to do all of this to sort of preserve my fertility for the future, as I didn't have a partner or the time to have a baby at that moment. My friends told me that, everything would be fine. I'm being too proactive. I'm being insane. And I just sort of kept full force knowing that this was a big priority in my life. I started my first round of egg freezing. The cycle was canceled after 2 weeks of injections and using up a lot of the prescription benefits. It didn't work. There was only one follicle there and the cycle was canceled. I was told then at 30 that I would need donor egg and that this was probably not going to work. And I left that office in tears too. And I can't even quite count all of the rounds that I went through. I know I went through a couple of more attempts at retrievals or different opinions. I did end up undergoing excision surgery for endometriosis and did do egg freezing afterwards, and actually ended up with much better results post-surgery than I did before. And most of the doctors that treated me were astonished and said, it can't be the surgery. Surgery's not that good. And I said, no, I feel great. I think it is the surgery. And, it's my wish that for patients, there's better collaboration like that and a little bit more open-mindedness and support for how you feel as a person and as a patient and what you're feeling when you're going through these treatments. After that, safe to say we tried several transfers. They didn't work. We ended up finding a gestational carrier and trying to carry with a gestational carrier, but we lost the baby at 16 weeks. At that point, it was really a low point for me and very difficult to come back to the OB floor and deliver babies and diagnose fetal demise when I had just been through this sort of situation. with a gestational carrier. So, even with that, I still had difficulty, and it was devastating. No one could believe why that would happen, and I remember still people telling me, it's going to be fine. You're going to get your baby. Stop trying so hard, and that was obviously very difficult to hear. And my best friend that, I still hold close told me, hey, this is actually just really a shitty day. And whatever you need, I'm here. Well, you want to walk through the botanical gardens and drink rosé in the middle of the day? We'll do it. And that was honestly the most support I had, was when people would say that things are difficult and there's nothing they can say to make it better. And honestly, the assurance and sort of understanding was the best thing that allowed me to wake up the next day, be hopeful again, and move on to something else. And so I always hold those friends dear to me that, really somehow just knew how to listen and be there, So I'd like to just say for those patients, I know the amount of times that you're told to relax, stop trying so hard, just drink a glass of wine, go on a vacation, get a little dog. You'll definitely get pregnant if you get a little dog. The amount of advice I heard, that I'm sure people were trying to be helpful, but these things were still painful every time, right? And I was then told, oh, once you get your baby, you'll always forget about this, and you'll deliver babies again, and you'll forget all of this that you went through. And I would say that I never forgot anything that I went through, and it's changed the way that I am as a physician, and it's changed the way that I am there for my patients and treat my patients. And so, and I still don't do obstetrics. That still was a painful thing for me, and I do, did ultimately achieve success, but it changed the way that I adopted practice and I practice medicine. And so I would like to say to everyone that I know it's a long and heartbreaking road. It's not easy. Days will be really hard, and you can have bad news and allow yourself the tears and build a support nest around you that actually listens and takes the time and just holds you in and helps you, right? And if there's people around that aren't like that, then allow yourself time and space to find some new friends or a new support for you. I would say don't beat yourself up about everything, even though it's very easy to do. I went to a retreat in Woodstock where we tried to grab our baby from the sky, hypnosis, tried pineapple rinds, eating 25 vitamins a day. You can imagine there's all sorts of things, I think that second and third and fourth opinions help. The fertility world is ever changing, and constantly new ideas are coming. And this is the promising part. This is the part that every day we hear something new and a new technique, a new trial, something going on. And I think that's really fascinating and cool to be a part of. I learned a lot in my journey, and ultimately, hopefully that helps our patients in some way. My goal and our goal in the practice is for transparency in the fertility realm, and ultimately to help patients with that, to have a transparent opinion from their fertility doctors and everyone that's supporting them and around them. Today, it's my honor to pull together some very dear friends and some of the brightest minds in this fertility world and ask them all of our burning questions and hear what they have to say about what is the hottest topic on the world today in the fertility. I hope that they can give you help or some ideas that may have not been suggested by others. And I want to wish everyone good luck in your journey wherever you are. And thank you so much for coming. It's my great pleasure to be here this weekend and present. Dr. Drew Tortiello is the medical director of Share Fertility Solutions in New York City. Dr. T, as he's known by his patients, strives to pursue compassionate clinical excellence. He has published a number of articles in scientific journals and is actively involved in research to further the development of reproductive medicine. He is a recipient of both a Women's Health Research Scholarship and a National Research Service Award from the NIH. Thank you so much for coming today.
Good day, everyone. My name is Dr. Drew Tortiello, and I am the medical director at Share Fertility Solutions here in New York City. And I'm honored and privileged to be able to give a talk today for the Endometriosis Foundation of America. and the topic of my presentation is silent endometriosis and immunologic implantation dysfunction. The incidence of endometriosis is prevalent. About 15% of all women of reproductive age are believed to have it. 70% of all women who present with chronic pelvic pain will ultimately be found to have endometriosis. And about 2/3 of young women with chronic pelvic pain or painful periods will have laparoscopic evidence of endometriosis, often severe. Endometriosis has a hidden or silent component, and it, in fact, may represent the largest percentage of endometriosis. About 30 to 50% of women who are undergoing unrelated surgeries were diagnosed with incidental endometriosis, emphasizing greatly that there is a frequent misdiagnosis of endometriosis for something else. Among asymptomatic fertile women who were undergoing a tubal sterilization procedure, up to 43% were found to have incidental endometriosis. And in an operative cohort, the incidence of endometriosis detected varied greatly by diagnostic procedures. Random biopsies taken would only have diagnosed it in less than 1%. About 7% would have been detected by MRI. 41% were actually diagnosed through visualization of disease. And in a cohort sort of random population assessment, MRI detected endometriosis in about 11%. We know that endometriosis is strongly associated with infertility, and about 40% of endometriosis sufferers will have infertility. The statistics are difficult to hear. Normal fecundity is about 15 to 20% conception rate per month, and of course will decrease with age. But women with endometriosis often have half or tenfold less the fecundity than their unaffected peers. Some studies suggest endometriosis causes an increase in the rate of miscarriage and lowers the live birth rate. And we know that infertile women are 6 to 8 times more likely to have endometriosis than their fertile counterparts. Why does endometriosis cause infertility? It likely is a polyfactorial presentation. Well, for one, we know that if a woman has painful symptoms, her libido will be diminished. There also is likely a pelvic factor. The inflammation associated with endometriosis can cause scarring and adhesions that block the fallopian tubes or hide the ovary behind a wall of scarring. They can also limit the closeness between the ovary and the fallopian tubes. There is also a postulated mechanism by which the eggs of women with endometriosis have less quality, maybe potentially a higher risk of aneuploidy. And there has also been postulated an endometrial receptivity defect. This receptivity defect seems to emanate from a number of reasons, but a dominant theory is that there is a progesterone resistance in women who have endometriosis. And lastly, and part of this talk, is immunologic implantation dysfunction. Endometriosis is a disease in which the immune system is altered in a manner that allows endometriosis implants to form and to thrive and grow. And this, in turn, is associated with an effect on implantation. The early detection and treatment of endometriosis is obviously crucial. Unfortunately for women, there's often a delay in the time between their symptoms beginning and the time that they are diagnosed with endometriosis. In patients who are between ages 18 to 45, the delay can be up to 7 years. It is paramount to suss out whether or not a young woman is at risk for endometriosis, because the sooner we suss this out, the earlier we can provide some sort of treatments which can mitigate their pain and the progression of their disease in negative ways. How can we help detect those women who may have silent endometriosis? Well, as of late, there have been some things emanating that evaluate the eutopic endometrium, that is the endometrium in the space of the actual uterine cavity, and by analyzing the eutopic endometrium, we can do some prognostication with regards to whether or not they have an abnormal ectopic endometrium, i.e. endometriosis. And two tests which have been developed that are endometrial receptivity assessments of a sort are the Receptiva DX test and the endometrial function test. Both of these tests are histological tests in which the tissue that is obtained from the biopsy is analyzed by putting on slides and staining. The Receptiva DX looks at aberrant levels of BCL6 protein, which is an inflammatory protein. And when present in high amount, this test is 93% sensitive and 96% specific for endometriosis. If you do nothing about these BCL6 levels, there's a less than 12% chance of a successful pregnancy following frozen transfer thereafter. The Receptiva DX also can assess integrin, which is a marker more specifically associated with receptivity timing. Treatment for abnormal findings on Receptiva, they are the treatments that you basically would expect for a woman with endometriosis. A laparoscopy or potentially the use of a long-acting GnRH agonist. And using a treatment will increase the live birth rate thereafter to about 64% in FET patients. Interestingly, the depot-lupron approach seems to have slightly better efficacy than the surgical approach. But my guess is with the enhanced surgical techniques that are used nowadays, that is likely to change very, very soon. The endometrial function test assesses the stromal glandular architecture of the endometrium and also for the presence of something called nuclear cyclin E. Nuclear cyclin E, when present in high amounts, denotes an immaturity, so to speak, of the endometrium, which is called glandular developmental arrest. The thing about the endometrial function test is that its findings, although indicating something is amiss, they're somewhat nonspecific, because you can find GDA in cases of endometriosis, hydrosalpinges, endometritis, extremes in body mass, and also in normal conditions such as the perimenopause or stress. Again, the treatment usually is something that we are familiar with, a depot-lupron sort of approach that will help reboot the uterine lining. I'd like now to talk a little bit, if I could, about the immunology of pregnancy, which is a very broad, complex, and interesting topic. But a general statement of truth is that a normal pregnancy requires a very unique adaptation of the maternal immune system such that an embryo is allowed to implant and thrive. If you think about it, an embryo is essentially foreign material to the woman. And why the embryo is not rejected along the lines of a kidney transplant, which, as you know, would require the mother to undergo an extensive amount of immunomodulation, is in and of itself a miracle of nature. Through a very complex cascade of events, the embryo is allowed to implant and invade into the endometrium. You can imagine how one simple step going awry could potentially lead to the failure of that embryo to implant and thrive. The extravillous trophoblast portion of the embryo, which diffusely permeates the decidual endometrium, expresses major histocompatibility complex Class I type genes. These genes, especially HLA-G, regulate the secretion of cytokines from natural killer cells and cytotoxic lymphocytes or cytotoxic T cells. There are two types of T cell cytokines, Th1 and Th2. Th1 cytokines foster cell destruction and clot formation, and Th2 cytokines foster trophoblast proliferation and expansion and angiogenesis or blood vessel growth. So in order for pregnancy to occur and to be maintained, there has to be a radical shift in the ratio between Th2 type cytokines and Th1 type cytokines. The hallmark of immunologic implantation dysfunction is actually an inappropriate dominance of Th1 type cytokines over Th2 type cytokines. And interestingly, there are other conditions in which Th1 dominates that we know about that are associated with various immune diseases, such as rheumatoid arthritis, celiac disease, multiple sclerosis, Hashimoto's thyroiditis, etc. Who should we screen for immunologic implantation dysfunction? I would recommend those who have otherwise unexplained recurrent pregnancy loss, those with a history of autoimmune disease, those with unexplained infertility, those with secondary infertility, those who have a history of unexplained intrauterine growth retardation due to placental insufficiency, and of course those who have a history of endometriosis, especially those who have infertility or miscarriage histories. Multiple studies have been published that suggest that the development of endometriosis or the progression of endometriosis is at least in part attributable to an abnormal maternal immune environment. Part of this has already been suggested by the association between endometriosis and multiple immune-mediated diseases. Endometriosis, especially when there's a concomitant infertility or miscarriage history, is associated with several deviations of the maternal uterine immunologic environment. How do we test for immunologic implantation dysfunction? Well, there are physicians who specialize in reproductive immunology that will do a very extensive workup that looks at various subpopulations of white blood cells and various levels of the cytokines or chemicals that are secreted. I tend to look at two key components of IID that I think have some prognostic value and provide some insight into what may be going on. I like to look at peripheral blood natural killer cell activity and DQ alpha or HLA type proteins. Natural killer cell activity is essentially a bioassay. It analyzes the ability of natural killer cells in a woman's blood to bring about destruction in an in vitro assay of cells that mimic the decidua or endometrial tissue of pregnancy. We know that women with high NK cell activity preconception have an approximately 3.5 times higher risk for pregnancy loss than women with normal levels. And more recent studies have shown strong correlations between high NK cell activity and recurrent miscarriage, and suggest that NK cell activity can be used as a predictive biomarker. HLA proteins, which can affect Th1 and Th2 cytokine ratios, are somewhat controversial as prognostic predictors. They don't seem to have a very high predictive value for future pregnancy loss, but we do know that after the fact, complete matches in DQ alpha are found at fairly high frequency in couples who have had multiple miscarriages. How should we treat IID? One of the first treatments that was devised and utilized was intravenous immunoglobulin. Intravenous immunoglobulin is essentially a blood product that consists of pooled antibodies from multiple blood donors. We know that intravenous immunoglobulin definitely, among many immune effects, has efficacy in affecting things that we believe are closely associated with miscarriage. IVIG produced a significant reduction in Th1 lymphocytes and cytokine levels. 87.5% of women in an IVIG treated group had a live birth in comparison to 41.6% in an untreated group. IVIG lowers natural killer cells and increases pregnancy rates in women with high levels in certain studies. Unfortunately, the high cost of IVIG, the theoretical risk of blood-borne infection, and the side effects, which include high fever, chills, nausea, tachycardia, have greatly limited its use. In the last 10 years or so, intralipid has largely replaced intravenous immunoglobulin. Intralipid is essentially a soybean-based form of nutrition that one receives through an infusion intravenously. Essentially, intralipid has been shown to have very comparable efficacy in lowering natural killer cell activity, and has been shown in certain studies to lead to an improvement in implantation, live birth rates, and a decrease in miscarriage rates. Intralipid has no real side effects and costs less than $50 per bag, so you can imagine why it has become popular as of late for IID patients. Corticosteroids are also a staple treatment for IID. They also lower natural killer cell activity. They bind to certain receptors and thereafter alter gene transcription. The gene transcription affects certain proteins that are known to cause damage. such as perforin and granzymes. But potentially most importantly, the production of interferon gamma, which is a key natural killer cell cytokine that causes problems for a developing embryo, is inhibited by corticosteroids. Corticosteroids such as prednisone, dexamethasone are inexpensive and have relatively few and minor side effects. Interestingly, metformin may hold promise as an adjunct therapy for endometriosis and IID. Metformin is known as a treatment for diabetes. We believe that it largely exerts its effect against diabetes through its anti-inflammatory profile. Interestingly, one clinical study that was recently done on endometriosis and metformin showed that metformin, when given to endometriosis patients with stage 1 or stage 2 symptomatic disease, had a significant decrease in their pelvic pain after 6 months, had a significant decrease in their dysmenorrhea, had a significant decrease in their dyspareunia, and had a significant increase in their pregnancy rates from 11.4% after 3 months to close to 26% increase in pregnancy rates after 6 months of trying to conceive. Future studies need to be done as this seems to be promising. Lastly, I'd like to leave you with a reasonable algorithm for the treatment of endometriosis-related infertility. Of course, this is subjective and different doctors may feel differently, but I think a reasonable approach would be to look at 2 different types of patients. Those patients who have clinically apparent or suspected endometriosis by virtue of their symptoms or findings on imaging studies such as large endometriomas or infiltration on MRI, those patients likely merit a definitive, conclusive treatment such as laparoscopy or long-acting GnRH agonist hormonal suppression. For those patients who have no clinical indication of endometriosis and/or an autoimmune history, those patients I think deserve 2 lines of investigation. One is an endometrial receptivity biopsy, which if positive, would also shunt those patients towards a more definitive treatment, laparoscopy or hormonal suppression. Second pathway of investigation would be for IID testing. And again, if those patients are positive, then at some point in their treatment history, you could consider something along the lines of intralipid and corticosteroid treatment. I like to work with patients who have already in place chromosomally normal embryos because we know the very, very significant and prevalent reason why women have difficulty conceiving and staying pregnant is simply the fact that the embryos are abnormal. That by far and away is the #1 reason for reproductive failure. But once you know that you're working with chromosomally normal embryos, then you can focus keenly on optimizing the uterine environment. And that's when I think the addition potentially of an endometriosis treatment or an IID treatment comes into play. I want to thank you very much for your time today. And again, it's been my pleasure to be able to speak with you all. Have a lovely morning.
Thank you so much, Dr. T. Now we have Kutluk Akte, who's an MD, PhD, a professor of obstetrics and gynecology and reproductive sciences, and also the director of Laboratory of Molecular Reproduction and Fertility Preservation at Yale School of Medicine. He is the world's leading expert in fertility preservation and a renowned ovarian biologist. He developed and performed the world's first ovarian transplants and pioneered innovative ovarian stimulation protocols for cancer patients. Dr. Akte discovered the role of BRCA function and DNA repair in ovarian and oocyte aging, and he has been continuously funded by NIH and other sources over the last 15 years, received national and international awards from professional societies and organizations for his contributions. He has been repetitively named one of the top doctors in Castle and Connolly, and he was even on episodes of Radiolab, which I was excited to hear. So thank you so much for coming, Dr. Akte.
Hello, hi there, and thanks for inviting me to join this event. It was a little bit of last minute warning for me, but I'm happy that I'm here. I was asked to talk about in general oocyte and ovarian tissue freezing for endometriosis patients. There's a lot on that for endometriosis patients, but we have a lot more information on patients with other medical issues and lately for elective reasons. So in this talk, I'm going to first give you the foundations about ovarian biology as it relates to cryopreservation procedures. And I'll be talking about oocyte and ovarian tissue freezing, both for healthy females and patients with endometriosis. Other than endometriosis, females with endometriosis are quite healthy a lot of times, so I think the data quite applies. Just a little bit of basic biology. If you think that what I'm showing you is too technical, I've actually done a little show on NPR, New York Public Radio, and you can actually, at this link, you can go and listen to that. It's called Primordial Journey, and it gives you an entertaining account of how ovarian follicles and ovarian reserve is formed. So if you type Radiolab and Primordial Journey, you will find the podcast on the internet. But just to give you about some information about egg reserve, the number of eggs in the female's ovary is fixed at birth, but those eggs are formed while you were a fetus in your mother's belly. And as a matter of fact, you had the most number of eggs, about 7 million, when your mother was pregnant for you for about 7 months, as this shows here. By the time you were born, you already lost 6 million of those eggs. So you're born with 1 million eggs in both ovaries combined. By the time you reach puberty, you have about 400,000 to 500,000 eggs left in your both ovaries combined. By the time you hit age about 37, there are about 25,000 of these left. And when you almost run out of them, menopause happens. So the menopause happens because you run out of your eggs. And then when you get to these later years of reproductive life, especially after 40, the remaining eggs are not very healthy. So the fertility rates are also specifically low. This slide shows you a study that was done by my earlier mentors, and I participated in some of the aspects of this. What they did was to count follicles, number of eggs females had based on cadaver ovaries. So again, the 1 million number comes from here. You're born with 1 million eggs, both ovaries combined. Then there's a steady decline up until age 37, 38. And after that, the egg reserve declines very sharply. So something happens around here, about 37 and 38. You start losing your eggs at a much faster pace. And by the way, not only egg reserve, but chances of pregnancy to have healthy baby also sharply declines about after age 37 to 38. So that's a critical age, and we try to do whatever we can. If you're trying to preserve fertility, perhaps shoot for below age 40 before this significant changes occur. But not only aging, but a lot of other things can happen during life that can take away the egg reserve from you. The most common of that is cancer treatments. However, there are other genetic conditions, familial situations, other immune diseases. And severe endometriosis is one of them. I'm going to come back to that. There are genetic conditions also associated with having low egg reserve. So all these are indications for us in preserving fertility. A number of years ago, we published a review on this, on fertility preservation options in women with endometriosis. So I just give you just a summary. It's been shown in multiple studies that endometriosis surgery decreases your egg reserve. So you're born with set number of eggs, and anytime a chunk is removed, you can't replace it. So your reproductive life is going to be shortened. Especially if you have repetitive surgeries, each time a cyst is removed, a piece of ovary may come out with it, further diminishing ovarian reserve. And on top of that, if you have one ovary removed because there was a really bad cyst, your ovarian reserve will be further diminished. And obviously, if you have radical surgery, if they're both removed, you will go into premature menopause. So fertility preservation discussion is highly indicated when there is severe endometriosis. I wanted to also give you some basics of how we measure ovarian reserve, because we keep talking about ovarian reserve. So how do we know where your reserve is? We have certain markers for that. Again, going back to some kind of biology 101, I said you're born with all the eggs you have. Those are the immature eggs, which we call primordial follicles. So if you were just born today, you would have 1 million of these in your both ovaries combined. These are not hormonally sensitive. We cannot give them FSH hormone and things like that to stimulate them to grow. I'm also a scientist. In my laboratory, we're studying what makes them to grow. Actually, I think we have a discovery. I always said that they're not sensitive to hormones, but I think we're discovering that there is something that stimulates them. But without getting into that, what happens is that currently, through an unknown mechanism, your eggs start to grow every day in bunches, 10, 20, 30. And then they go through this at least 3 months journey before one of them takes the lead and ovulates and the other ones die. So it's really a wasteful process. For every egg you ovulate, you're wasting about 1,000 eggs. So your ovaries have a lot of redundancy, extra reserve. So when we do, for example, ovarian stimulation to freeze your eggs, or we freeze your ovarian tissue, we take advantage of that redundancy. We tap into that extra reserve. So there are some markers that can measure your egg reserve, and there are markers that from the blood test that we can look at. One is called FSH and the other one is estradiol, but these tend to fluctuate in your cycles up and down. So we need to measure this on the 2nd or 3rd day of the period. There's another marker, inhibin B, also measured early on, but again, it's not that sensitive. Another way that ovarian reserve can be measured is by an ultrasound and looking at small follicle counts. Again, this has to be done early in the cycle. It's called antral follicle count. So that's what we do initially. We ask you to come in beginning of your cycle. We do these tests. However, there's a test that's by and large independent of your cycle day. We call that anti-Müllerian hormone. Now, the anti-Müllerian hormone is produced from these early stage follicles. There's no hormone that's produced from primordial follicles, but since they're produced from that, and this population of follicles by proportion represents these numbers represent your egg reserve. So far, this is the best marker, because as you can see from this graph, it represents the closest time point to your egg reserve in follicle growth than antral follicle count or inhibin B. And as I said, serum FSH and estradiol are not that specific because there are a lot of factors that can affect their levels. So this would be the kind of assessment we would do, but we would put most weight on AMH and the antral follicle counts when we try to assess your reserve. So if you have gone through repetitive surgeries, you should get your ovarian reserve assessed. And I also recommend have your ovarian reserve assessed before surgery and about 3 to 6 months after surgery to see if there was a loss. And that can also maybe help you with the alarm bells, because if your ovarian reserve is diminished, if you wait longer, it will get lower and lower. So you may want to be proactive before it gets even further low. So I said I was going to talk to you about oocyte and ovarian tissue freezing. So oocyte freezing requires about 2 weeks of ovarian stimulation with what you call fertility drugs or ovarian stimulant drugs. And then there's an office-based transvaginal egg retrieval. Ovarian tissue freezing, on the other hand, requires a 1-hour laparoscopic surgery, again, as an outpatient procedure, but there's no need for medications. So let's take a look at these two procedures. First of all, how effective or successful is egg freezing. So here is a large study looking at women who underwent egg freezing for elective reasons, meaning social reasons, or medical conditions other than cancer, which includes endometriosis as well. What we are seeing here, the success rates based on whether they were 35 years of age or younger or older than that. So what you see here is that patients who are younger than or equal to 35 had at least 50% chance of live birth. But once you go above that, it goes to half of that. If you look at more specifically age brackets, you can see that if you were 29, you had 100% chance, but between 30 and 34, it dropped to 45. Between 35 and 39, it dropped to 28.5. Once you're 40 and above, it drops to 3.7. So what does that tell us? Yes, if you're going to freeze your eggs, don't wait till you're past 40. So that's what our recommendation is. This data also shows us a different aspect of it. If you're 35 or younger, we can increase your success rates by freezing more oocytes. Cumulative live birth rate goes up to about 85% with 15 oocytes. But if you're older than 36, it kind of gets stuck around 11 eggs based on this data. Maybe we cannot increase the chances that much higher than 35%. So again, that tells you to do this sooner. We've also looked at the success rates in another large study. On our website, fertilitypreservation.org, we have an egg freezing success rate calculator. Again, a lot of these patients had infertility issues, so their success rates might be lower compared to patients who are healthier. But it does give you a relative idea based on how many eggs you want to freeze and when you want to use it. Again, from our study, just to show that by age how egg freezing success rates drop, there are two main methods of freezing. One is called slow freezing, and the other one is vitrification. The slow freezing success rates are here, and based on how many eggs are frozen, and vitrification is here. This is the reason why all egg freezing is done with vitrification now, because the success rates are much higher. Sometimes some of the differences in success rates can be overcome by putting more embryos. But again, as I said, there's a limit to that, and putting more embryos increases the risk of multiple births. So the best thing is to do the egg freezing as early as possible with large numbers. Sometimes question is asked whether a fresh egg is as good, a frozen egg is as good as fresh egg. The numbers are approaching, but not necessarily. This is one study where they looked at the success rates of IVF with fresh donor oocytes versus cryopreserved donor oocytes. Now, these donors are all in their early 20s, so they have the best egg quality. Even with them, you can see that if it's fresh, 49.6, frozen 43.2. As you get older, that difference will be larger. In another study with infertile patient population, it was shown that if you use frozen eggs compared to fresh, those eggs result in half the number of embryos, blastocyst embryos. So that means that you will get fewer embryos from frozen eggs, and that's something to bear in mind. Now, how about ovarian tissue freezing and transplantation? This is a technique that I first developed and described in the year 2000. What we do here is that we remove a portion or a whole ovary, depending on the circumstances. Definitely in cancer patients, when treatments are going to put the patient in menopause, we take more, but in healthy women, we take less. I will get back to that. And then the ovary is separated from its connective tissue, and they're prepared in small slices so they can be fit in little test tubes, which have anti-freeze substances, which we call them cryoprotectants, that will protect them during the freezing process. We use an automated computerized machine to slowly freeze them and bring them to liquid nitrogen levels. After that, they're shipped to a long-term bank, and some patients end up using it 20 years later. Nothing happens to them in freezing. I've developed two different techniques of transplantation. One is, years later, you wanted to have your tissue back, you come back. For patients who want to have babies, we prefer to put it in the natural location. We call it orthotopic or pelvic. But in other patients where pelvis is not suitable, let's say they have scars, or the only reason they want this is for hormonal, then we developed heterotopic transplants where we put the tissues underneath the skin. This is the first transplant that I described in year 2000. This is a patient who had lost both of her ovaries, but one of the ovarian tissue was frozen. And when we transplanted back, she got her egg development and hormone production. She wanted this for hormonal production, not for babies. And this was the first case to show that menopause can be reversed this way. I've also afterwards developed a simplified method, as I said, by putting the ovarian tissue underneath the skin. You see these patients, the initial patients, I did it under the forearm because parathyroid transplants are done there. There was an example. But however, as you can see, when patients are about to ovulate, they form a bulge here. This is a follicle, as you see in the patient's muscle. So there were some cosmetic issues. So then we changed the location to abdominal wall. And this is where we normally put it. We were able to get embryos from this location as well. But as I said, I currently preserve this for patients who want to do the transplant for hormonal reasons, because we can do this under local anesthesia, and the cost-wise it's lower. So as I said, from the 90s, from the earlier developments, lots of developments have happened. Now we got to about 2022. We have lots of babies from transplants, and we recently looked at the 20 years experience of the entire globe, not just ours. And this slide shows the summary of that. The gist of it is that most of these patients are young cancer patients. They didn't have any issues other than that. Their ovarian reserve was normal when the tissues were collected, and they were young, as you can see, mean age of 29 when it was frozen. But nevertheless, world experience is about 25% live birth from these patients, and about 2/3 of these women, the menopause is reversed. So they can, 2/3 can spontaneously conceive without the need for IVF, and almost 80% they had their menopause reversed. However, we have advanced the techniques by using robotic surgery and with some vascularization enhancing agents. Here's a robot that I operate with, and this significantly improves outcomes, as we recently showed in a study. All the patients we've done that we were able to reverse menopause and generate embryos, or those who attempted pregnancy, and they were pregnant. So all these new techniques are really improving success rates with ovarian freezing and transplantation. There is now more discussion about using this to delay menopause, to delay reproductive aging, and we've recently published on that. And the questions were, if you're doing this to delay your menopause, will this provide you, once you freeze it and transplant it, give you reliable hormone production? And my experience with cancer patients, yes. I have many patients with 4, 5, 6 years of function, and they go through regular cycles in most cases. One question is how much tissue to remove. I mean, in cancer patients, if they're going to lose their ovarian function anyway, it's an easy question. But you're healthy, we don't want to take too much and put you in menopause or early menopause, but we don't want to take too little that's not enough to transplant. So the cost effectiveness is a tough question. Again, based on egg freezing studies, the cost effectiveness is maximized around age 35 or so if you're going to delay your childbearing for about 5 years. Are there any ethical medical issues associated with delaying menopause? One question is, would we increase the risk of breast cancer if you're delaying your menopause? And we know now from Women's Health Initiative study with hormone replacement is that if you start hormone replacement as soon as you enter menopause, between age 50 and 60, your benefits are much higher than your risks. So we think that it would be similar with ovarian tissue transplantation for these purposes. And is it superior to elective egg freezing? So your advantage with ovarian tissue freezing and transplantation is you have, instead of dozens of eggs frozen, you have hundreds of thousands of small immature eggs frozen in that ovarian tissue, because in one ovary you may have, depending on which age you were doing, tens of thousands of eggs, and then it restores natural fertility, and you can conceive spontaneously. So these are quite advantages. One question is, let's say we want to take a piece of your ovary to freeze it, would that put you in early menopause? Since this approach is relatively new in healthy women, we don't have direct studies for that. But there are studies looking at what happens if a woman has one of her ovaries removed. And it seems that for most studies, the difference is either a couple of years. So they may end up going to menopause a couple of years earlier, unless it's done as a child. That's about 7 years or so. And this is with the whole ovary removal. So as I will show you, for a healthy woman, we are thinking of probably about a third of an ovary. So this should have minimal effect. So is there an experience with ovarian tissue freezing and transplantation in a healthy woman? There wasn't until recently, but in collaboration with Dr. Petrikovsky, this is a study was performed in overseas, but we helped them complete the data analysis. What they did was that healthy women undergoing C-section, tubal ligations, myomectomies, endometriosis surgery, etc., had about 20% of their ovarian cortex removed, and it was frozen for future transplantation to delay their menopause. And they were about 26 at the time of the entry. So they also had a healthy control, which this wasn't done. So they looked at the age they entered menopause. At the time of this analysis, there were only 20 of those who came back. But when you look at them, it seems like the age that they entered menopause is similar, and there hasn't been a case of premature menopause. The same group also transplanted ovarian tissue from 5 women as such, and then they assessed their satisfaction with menopausal symptoms. 4 out of 5 we said either excellent or acceptable. One of them, the graft had to be removed due to infection. But what they did here, which is bizarre for me, to put the transplant underneath the axilla, so your armpit, which is probably not the most sanitary place. We don't do that. As I said, we will put it in the abdominal wall, if anything, forearm. So I think that's the reason for infection. Otherwise, this shouldn't happen. So this again shows the feasibility of doing elective ovarian tissue harvesting. Now, the next question is, okay, we did collect the tissue, freeze it, and transplant it. Is it going to provide sufficiently extended reproductive lifespan or hormone production? Because one thing, what happens with ovarian freezing and transplantation, you are losing about, during the process with the conventional methods, about 60% of all the eggs in there during the process. But we think our robotic approach with some neovascularizing membranes may overcome that. So as I told you, this is how egg reserve goes, and then there's a sharp decline at age 37. And now we did an estimate. Given the age and the rate of follicle loss, how much tissue we would need to take from somebody to, let's say, have 5 years of function. And what we found was that with the old techniques, when you're losing about 2/3 of all the eggs in there, you would have to take a lot of tissue. But as that loss is less with improved techniques, for example, almost nothing, so we could take less and less to provide at least 5 years of function. So we have these kind of calculations to discuss with patients. I must say that, as I said, we have developed some agents that could potentially be used in the future to enhance graft vascularization so that it can prevent follicle loss. These are some of the agents in addition to robotic surgery, and there are some others tried in animal models, etc. So going to the future, we're going to see further improvements in success rates with frozen ovarian tissue. So based on all that, what we are doing is we are for healthy women, or if you have endometriosis but your ovarian reserve hasn't been impaired, we would limit the tissue harvesting to 1/3 of an ovarian cortex. Obviously, if you're having a surgery where they're going to remove both of your ovaries, we can preserve whatever healthy tissue is there. Or if they're going to remove an entire ovary, we can go in there and then save as much healthy tissue as possible, because that ovary is coming out anyway. And then these eggs are sitting on the surface of the ovary, what we call cortex. So we don't actually cut the whole ovary. We just lift up the surface, like peel it off, and that layer contains the immature follicle. So that minimizes the adhesion risk. And then, obviously you have endometriosis, you're undergoing another procedure, so you don't have to have a separate procedure for this. But if you were healthy and you're not, you don't have any other indications, it would be good if you had another procedure that we can time it with. Otherwise, you would need a laparoscopy additionally for this. And as I said, we recommend assessing ovarian reserve before doing that. If your reserve is already highly diminished, this may not be ideal for you. And then we would have a discussion with you, just like I had with you in my talk about this, and you would sign a informed consent, and we'll tell you what limitations we have. And again, as I told you in my lecture, that we are highly recommending for you to do it under less than 40 years of age, especially you're doing this for fertility preservation reasons. For hormonal reasons, maybe there may be some leeway, especially if your egg reserve assessment is good. So we individualize these cases. And in the future, as I said, if we are doing this for restoring hormonal function, transplanting under your skin might make it simple, because this could be done under local anesthesia in the office at much lower cost and provide you all the hormones you need. So in conclusion and summary, there are several fertility preservation options for endometriosis patients and for those without medical reasons. The success of IVF with frozen oocytes is satisfactory, but it's not equal to that of with fresh oocytes. On the other hand, ovarian freezing and transplantation success rates have risen. The advantage of ovarian tissue freezing and transplantation over egg freezing is that it can restore natural fertility and reverse or potentially delay your menopause. And you may be able to have this surgery under local anesthesia and an outpatient basis. So endometriosis patients, and I assume all of you are in the audience or related to one, if you're undergoing surgery, have your ovarian reserve assessed, and at the same time have counseling on fertility preservation options to see if these are suitable for you. With that, I would like to thank you for listening to me, and I would like to also thank my team at Innovation Institute for Fertility Preservation based in New York, and also my research laboratory at Yale based in New Haven, Connecticut. And if you have any need for further information, you can go to our website, fertilitypreservation.org, or you can email us at info@fertilitypreservation.org. Thank you again, and have a good day.
Jenna, and my fertility story started back in 2018. We decided we wanted to have a baby, and come the spring of 2019, I started to get concerned that maybe something was going on. I knew my mom had endometriosis, and I suspected I might too. I spoke to 2 different OBGYNs, one who thought I did, the other who said I absolutely did not, and that I should keep on trying. After about a year of trying, we got up the courage to go see an endocrinologist, reproductive endocrinologist, whose recommended course of action was to do a couple of IUIs and then go to IVF if unsuccessful. And that's what we did. We had several unsuccessful IUIs, which is no surprise given how extensive my disease was, which I didn't know at the time. And then we did a retrieval, and while it was successful in that it yielded a couple of healthy embryos, it was excruciatingly painful and tough on my body, again, because the disease was as extensive as it was. We then did a transfer, which did not implant, was unsuccessful, which was really, truly devastating. And when that fertility clinic recommended that we just try again with the same protocol, I really felt that that didn't feel right to me. I didn't want to go do the same exact thing expecting a different result. And so I sought out the counsel of Dr. Sechkin and Dr. Goldstein, who immediately understood me and discussed my symptoms with me and talked to me about silent endometriosis, and I opted to get surgery, and thank God I did, because it was quite a significant case. And I felt so comfortable with them that they were doing everything in their power to help me get pregnant, and they did their job, because a few months later at a new fertility clinic, I was able to have a successful transfer. The embryo implanted, and I believe it was because I was able to have a healthy environment, and that helped me sustain a pregnancy, one that was actually quite vanilla after all I went through. And now today we are the parents to a healthy baby boy who's 3 months old. And it's hard to believe, and it was quite a journey, but for anyone who's really in the thick of this right now, just my advice is to go with your gut, be your own advocate, and really don't be afraid to take action to do what you feel is right for yourself and your family.
Thank you so much, Dr. Aktay, and thanks, Jenna, for your story. Next, we have Dr. Tomer Singer, who is also an MBA. He earned his medical degree from Sackler School of Medicine and an MBA from Hofstra School of Business. He completed residency and training at Lenox Hill and an REI fellowship at Weill Cornell Medical College in New York, and is now at Shady Grove Fertility Clinic in Manhattan. Thank you so much for coming. Excited to hear what you have to say.
Good afternoon. So it's a pleasure to speak again in the Endometriosis Foundation of America conference. I think it's been over a decade now, and it's always a pleasure to talk about a topic that's near and dear to what I do on a daily basis. I would like to thank Dr. Tomer Sechkin and Padma Lakshmi for the invitation. We'll be talking today about creative options for fertility treatment for patients who suffer from endometriosis, and the focus will be on talking about oocyte donation and gestational carrier. As we can see here, there's different staging for endometriosis, and today we'll focus on patients that are suffering from at least stage 3 or stage 4, which usually causes an involvement of both ovaries, the fallopian tube, and the uterus. We know that the endometriosis can affect all the organs that are involved in fertility, and it can affect implantation, egg quality, ovarian reserve, and puts the patient at risk for both miscarriages and ectopic pregnancies. Egg donation and gestational carrier has been around since the early 80s and have been a good solution for a lot of patients who underwent surgery to remove ovaries or fallopian tube, or to remove the uterus, or remove all pelvic organs. What we can see here is that the endometriosis lesion can affect the ovary, that's where the eggs are derived from. It can affect the fallopian tube, and that's where an embryo usually travels after ovulation for about 5 to 6 days before it implants in the uterus. And it can affect the uterus itself, where an embryo needs to grow for 9 months or 40 weeks. These are some images from intra-op finding from IVF patients of ours, and we can see that fertility can be affected just by looking at the ligaments that are involved with endometriosis lesion, the fallopian tube that are becoming stiff and cannot really do what they're supposed to do, which is allow the sperm to travel from the uterus into the fallopian tube, and later on, after fertilization occurred, to allow that embryo blastocyst to travel back into the uterus and of course impact the uterus itself and can cause both failure of implantation and a miscarriage. Some of the indications for egg donation are prior surgeries, and as we know, patients with endometriosis do tend to have surgeries and sometimes multiple surgeries. Another indication for that is failure of out of treatment. We know that patients with endometriosis have to go double as many cycles of IVF when they get to a point of needing in vitro fertilization. And the reason for that is both egg quality and uterine implantation issues. We know that a lot of patients will have decreased ovarian reserve, premature ovarian failure. Patients that are even in their early 20s have to undergo an extensive laparoscopic endometriosis resection, and at that point their ovarian reserve testing, as we assess it with AMH, anti-Mullerian hormone, and FSH, follicle stimulating hormone, suggests that the likelihood of them conceiving using their eggs is very low. Here we can look at this graph that was published in 1992 that showed that women with diminished ovarian reserve can benefit from egg donation when they're in their early 40s or mid 40s. In this slide, we can see that egg donation is the only option for women in their mid to late 40s. Endometriosis patients tend to have much lower ovarian reserve at any age group. So if a patient is 30 years of age with endometriosis, her ovaries may have less follicles and the patient will have less chance of conceiving using her own eggs, especially if a patient had ovarian resection or ovarian cystectomy, which is a removal of a cyst or an endometrioma, and especially if the patient had removal of both ovaries. Patient can conceive using donor egg even without ovaries and fallopian tube. In that case, all we'll need is the uterus. In this slide, we can see that even patients without any ovarian reserve left or diminished ovarian reserve, or even patient who had removal of both her ovaries and fallopian tube, have a very good chance of getting pregnant even when they're in their late 40s. What we can do with this data that is published by the CDC is extrapolate it to patients who lost their ovaries due to endometriosis or had significant or extensive surgeries on their ovaries, and we can reassure the patient that with egg donation, their chances of getting pregnant is very high with their own uterus. This slide shows that with age, the egg quality goes down and the embryo quality goes down. We see here that at age 42 and above, only 10 to 13% of all embryos will be euploid, meaning balanced males or females. When we look all the way to the left-hand side, we see that even when we use egg donors, some of the embryos will be chromosomally abnormal, and I'll touch upon that when we talk about the process of egg donation. In the next slide, we can see that the donor egg recipient, in this case the endometriosis patient, have several options to choose a donor egg. It could be a family member, which is a designated egg donor. It could be an egg donor that's undergoing an IVF or stimulation for an egg retrieval for the purpose of donating her eggs anonymously, and that's really the common way of doing egg donation. It could be using an egg bank. In that case, donors have already cycled and their eggs are already frozen in lots in one of the commercial egg banks. And it could be an egg donor that's being screened by an agency, and then the IVF center is stimulating her for the purpose of using those eggs with the husband sperm or donor sperm. What really changed what we do in the third-party reproduction, which is the title name for egg donation, gestational carrier, and in some cases sperm donation, is that since 2012, we have seen that the pregnancy rate is very similar when we use frozen eggs compared to fresh eggs. And that really revolutionized the treatment that we can offer now endometriosis patient. If in the past, the only way to do egg donation was to use a family member or to use a friend or to use a fresh anonymous egg donation, now we have egg banks, and that shortens the timeline for a match. It also expands the amount of donors that we can offer patients, and specifically for a specific ethnicity group, and whether it's Jewish, African American, Asian, this is sometimes can mean a faster treatment by 6 to 12 months. So egg banks are really here to stay, and in many ways, probably in a 5 to 10 years time, will be the bulk of how we do egg donation. Whereas if we look at the CDC database from 2020, it's about 40-60 as the data shows us. egg banking is probably the future for several reasons. It reduces also the risk of contamination of the eggs with infection, hepatitis B, C, HIV. We now know that with donor sperm, we have to use frozen sperm from sperm banks. And at this point, even though about half of the cases are still done with fresh egg donation, we know that there is a risk that the recipient is taken by having an embryo that's going to be transferred 5 days after it was retrieved from the anonymous egg donor. So by freezing the eggs of the egg donor, we can retest the donor for all those infectious disease and provide reassurance to the patient who is selecting that donor. There's different commercial egg banks, as you can see on this slide, and up to as of 2021, more than 10,000 cycles have been completed in the U.S. alone, and it is estimated that more than 5,000 babies have been born using egg donation via egg banks. The bulk of our transfers will include a single embryo transfer to reduce the risk of twins and triplets. So if we have to summarize what are the advantages of using egg bank for a patient who has stage 3 or stage 4 endometriosis, who presents with the failure of previous treatment or have a very low undetectable AMH or very high FSH, then the advantages are faster time to match. There's lots that are waiting in those commercial egg banks, and the patient can start screening those profiles and be able to choose within a few weeks' time the desired donor. There's no need to synchronize the donor egg and the recipient, and it widens the donor selection, and in many ways it gives the donor egg recipient, and in our case the endometriosis patient, much more control, especially if that patient is undergoing other treatment for endometriosis or is currently having to undergo medical treatment for the endometriosis, whether it's a GnRH agonist, Lupron, or surgery, or birth control pills to calm down a flare of an endometriosis event. The disadvantages of using an egg bank is that there's a limited number of egg donors, and also there's a limited number of egg lots from that specific donor. So as I discussed with many of my patients who would like to have 2 kids, in many cases, that patient, when she chooses an egg bank as her egg donor source, may have to choose a second donor, a different donor for baby number 2, if that specific desired donor only has 5 eggs or 8 eggs, given that there's a limited number of eggs in those egg banks. When you do an egg donation, you have to follow very strict guidelines. The American Society of Reproductive Medicine, the CDC, the FDA are involved, and different state regulation apply. The donor has to undergo psychological consultation, and so does the recipient, whether she's a single patient or with a partner. The evaluation of the oocyte recipient, which is the endometriosis patient in our case, who has diminished ovarian reserve, will include a general physical exam, all the preconception testing that we would do anyways if the patient used her own eggs, and then we'll basically assess the uterine cavity. We want to make sure that the patient can carry the pregnancy and not just go the route of egg donation before we make sure that the uterus itself is competent and can build an endometrial lining, has a good blood supply, and has a good chance of having a full-term delivery. That assessment can be done by doing a saline infusion sonogram that in many cases looks for polyps, fibroids, or any lesions. It can be done by a hysterosalpingogram, which is essentially an X-ray of the uterus and the fallopian tube, and it can be done via hysteroscopy, which is a procedure that's done in the surgery center, just like we've done today in several patients, looking into the cavity, sampling the endometrium, which is where the embryo needs to implant, and making sure that there's a good blood supply and a good chance of an embryo transfer to succeed. The evaluation of the partner of the recipient, if that's applicable, will include genetic testing. We need to make sure that the partner and the donor egg are matched and are not carrier for the same genetic condition. We need to make sure that that partner is negative for hepatitis B, C, HIV, syphilis, and we have to make sure that we know the blood type and work around getting a semen analysis and making sure that we're using the best potential sperm for the fertilization of the donor egg prior to an embryo implantation. The donor screening is outlined here. We use young patients who are 21 to 32 years of age, normal weight and height, non-smoker, healthy medical and family history, normal FSH and AMH. They'll have a consultation either with a physician, a PA, or nurse practitioner, and then they'll have also a random negative drug screen. We'll do the testing as required by FDA, hepatitis B, C, HIV, syphilis, and then we'll do the genetic testing. Usually we'll use a very extensive panel with more than 250 genes by one of the commercial genetic labs, and make sure that if there is a partner, that partner is negative for the same genes, or if it's a single patient who's using a donor egg and donor sperm, that the donor sperm and the donor egg are going to be a match as well. And then, as mentioned, the psychological evaluation of both the donor and the recipient. So this is just a list of some of the testing that we're doing. The psychological evaluation is intended to make sure that the donor egg is not doing it because she's coerced or being incentivized to do it, and really not really completely on board with the egg donation process. We want to rule out drug use, suicidal or criminal record, eating disorder, learning disorder, abuse or neglect, and the approach of that donor towards the donation process. This slide shows the process that the donor egg will have to undergo. Usually it takes about 12 to 14 days to complete the process, and the donor egg will have to self-administer it, or a nurse will help her with administering the injections. Those injections get a title name of gonadotropins, which include about 3 or 4 different medications that helps recruit many follicles. Each follicle potentially can contain 1 egg. And at the end of this process, the patient is taking a trigger shot and undergoing a procedure in a surgery center under conscious sedation, and those eggs are being retrieved transvaginally with an ultrasound guidance, and those eggs will be distributed either to a 1 egg recipient or more than that, or be frozen for an egg bank for use in the future. What you can see here that once we get the eggs, we inject the partner or the donor sperm, and we can create embryos. Those embryos will grow in our IVF lab and will be watched until day 5, 6, or 7, what we call the blastocyst phase. At that point, the patient will have 2 options. One option is to freeze that embryo without any further testing, and another option is to test that embryo. In many cases, we also do a fresh embryo transfer without having to freeze the embryos. But given the logistical challenge, this has fallen out of favor. And in many cases, especially with endometriosis patients, which we try to avoid prescribing estrogen if possible, we would freeze the embryo and then work with the patient's own natural cycle and her own uterus by following her dominant follicle, waiting until she ovulates, and then 5 days later, because the embryo is a day 5 old, do the embryo transfer, whether it's a tested embryo or untested embryo. What we know that we have a lot of supernumerary embryos. What does that mean? We have a lot of embryos that are in the freezer that no one is claiming, especially in the situation of an egg donor. An egg donor sometimes will have 20, 30, 40 eggs that are being retrieved. And if a couple of the recipients want only 1 child, you're going to have a dozen embryos that no one's going to claim, and they're going to be in liquid nitrogen frozen for years, where if we split those eggs, it can help other couples. So what we've done at SGF is we have a very robust program of a split egg donation cycles, which allows us to take 1 donor and split it among 2 or sometimes 3 recipients. In fact, 40% of our egg donation cycles are split among 3 recipients, meaning if the patient gets 18 eggs, the donor gets 18 eggs, it can be divvied up between 3 recipients, and each recipient can get 6 eggs, and the pregnancy rate stays very similar in the 50s and 60% per embryo transfer. What it does for us, it reduces the waiting time for the intended parents or for the recipients who are waiting for those eggs anxiously. The second big advantage is it lowers the cost, because we pay the donor, and that can be divvied up between 3 recipients. We pay for the medication, we pay for the procedure. So it's only clear that if 3 recipients will share with 1 donor, it will lower the cost significantly and will make it much more feasible and much more affordable for many patients who otherwise cannot afford egg donation. And as I mentioned, it limits the extra embryos that are going to be frozen and no one's going to claim for decades on end. The exclusive cycle is when the donor egg gets retrieved and all the eggs goes to 1 recipient. It's still a common way of doing egg donation when you use an egg donor through an agency. And in some centers, they don't feel comfortable splitting eggs, or in a very unique ethnicities that there's difficulties in finding a match with 2 recipients. and that recipient will be receiving all those eggs and have frozen embryos for the future to use for baby number 2 and baby number 3. But the shared cycle is here to stay. It is the better way to actually accomplish egg donation cycle, because it really helps more couple, reduces the cost, and will limit the amount of unused embryos. The cost that I mentioned is really one of the rate limiting steps in this treatment, besides the emotional aspect of the patient who undergoing multiple fertility treatment that have not been successful leading up to an egg donation. And it is average between $20,000 and $30,000 per cycle, whether it's using a fresh egg donor or whether it's using a lot of an egg bank. It's pretty much a similar cost. And the main reason for this cost is that the donor gets compensated, the medications are very expensive, the donor has to come for multiple blood tests and ultrasound, and then later on the procedure in the lab, injecting the sperm, creating the embryos, and having those embryos tested for genetic screening or for freezing and the later embryo transfer is very expensive. We are very proud of the fact that over 99% of our donor egg cycles are elective single embryo transfer, meaning the recipient had more than one embryo that she could have chose to transfer, but followed our guidelines and instruction and transferred a single embryo. Very rarely, when a patient had failed multiple cycles or has a uterine factor or other reason regarding the embryo quality, we will allow doing more than one embryo transfer. But those are really very rare events. The embryo transfer itself is essentially a transfer of an embryo, which in the vast majority of cases is going to be a blastocyst embryo, day 5 or 6 embryo, that is going to be transferred under ultrasound guided into the recipient uterus. And the preparation leading up to that embryo transfer will take about 2 or 3 weeks, which may involve estrogen or not. We can do it in a natural cycle, but definitely will involve progesterone administration, which will help with implantation. The transfer itself is painless. The patient is awake. We do it on a complete strict protocol. We confirm that the embryo belongs to the recipient, and 2 embryologists and 2 physicians will sign off on this embryo transfer. And then about 10 to 12 days later, we'll find out if the patient, in fact, is pregnant. And again, a single embryo transfer of a blastocyst is what we perform in well above 90% of our cases. One thing that's important to mention is the obstetrical outcome of the donor egg recipient. So now you have a patient with endometriosis who basically has multiple surgeries in her ovaries and fallopian tube and has some pelvic adhesions and has diminished ovarian reserve. So we know that there's an increase in preeclampsia, which is essentially a condition that's unique to pregnancy, which involves blood pressure that's elevated with some protein in the urine. And there is diabetes in higher rate, and a lot of those patients will be at advanced maternal age and over 40. So there is a built-in bias there, because as the patient is older, there is a higher risk for diabetes, and there is a higher risk for operative delivery, like a vacuum or forceps, and higher risk for C-section. And it's considered high-risk pregnancy in many institutions, given all the process that led into that embryo transfer. But overall, very good outcome with very good pregnancy and take-home baby rate. This is a good segue for talking about gestational carrier, which is a situation that the patient cannot carry with her own uterus. So some of the indication of using a gestational carrier is either born without a uterus or having a hysterectomy due to endometriosis, stage 4 usually, a non-functional uterus, patient who has severe endometriosis with adenomyosis or had multiple procedures done on the uterus and the endometrial lining is not getting thick to the level that we can feel comfortable that an embryo will implant, and some medical contraindication for pregnancy, which is something that is very common also in endometriosis patients who suffer from pelvic pain, ligamental pain, dysmenorrhea, dyspareunia, pain during intercourse, during the menstrual period, and during bowel movement. So some patient will have such a debilitating pain with endometriosis that it wouldn't be safe to do an embryo transfer and put them at risk for 9 months with high levels of estrogen that's being secreted by the placenta and high level of progesterone. And in those cases, we will be choosing the option of a gestational carrier. A gestational carrier is essentially a woman who bears a child that's genetically unrelated to her, and it's done for the individual who's essentially going to be the intended parent or the legal parent. And it could be using a donor egg, or it could be the intended parent's own genetic eggs. So if an endometriosis patient doesn't have a uterus but has her own ovaries and can have an IVF done or an egg retrieval, we can use our own eggs with a partner sperm or donor sperm and use it in a gestational carrier to carry that pregnancy because of contraindication for her being pregnant. The intended parents are those individuals contracting with the gestational carrier, and it's not always the patient who is the genetic mom or dad. So there's different scenarios, and then in many cases we will use a gestational carrier with a donor egg or with their own eggs. Over 1,600 cases per year of live birth have been reported in the US using a gestational carrier, and it changes from state to state. There's different legislation. As someone who's practicing in New York State, it's been approved as of February 2021 and legal to pay for a gestational carrier, which was essentially a non-very common procedure in New York State prior to that, February 2021. This slide shows all the scenarios that we have. So the way we think about it is, where is the egg coming from, which sperm we're using, and which uterus are we using, and if it's a gestational carrier, is it a family member or a friend, or is it a recruited gestational carrier that's going to be paid? So if a patient has severe stage 4 endometriosis and had oophorectomy, which is removal of the ovaries, and had a hysterectomy, that patient will have to use a donor egg and a gestational carrier. If she happens to be single, she may be using also a donor sperm in this process. If the patient is using her own eggs and just the uterus is non-functional, this will be her own eggs with the sperm of a partner or a donor sperm and a gestational carrier. And if the patient has low ovarian reserve, low AMH, high FSH, but her uterus is functional, this will be a situation when we're using a donor egg, but the patient's own uterus. The gestational carrier recruitment takes anywhere between 4 to 12 months, and it's been actually more challenging during COVID. A lot of the gestational carrier are not vaccinated. We recommend that the GC will get vaccinated given the risk that has been shown during pregnancy for both the mom and the fetus that she's carrying. It could be a family member or a friend willing to be the GC, and it could be a sister, a cousin, or really even just a close friend who's willing to help. And while recruiting the gestational carrier, the intended parents will undergo IVF herself to get the eggs with the partner or donor sperm, so those embryos are ready to go once the GC has matched. Or alternatively, select the donor egg if she's not a good candidate for undergoing IVF. That way, the embryos are ready for a transfer into a gestational carrier. Some of the requirements are outlined here. A gestational carrier should be younger than 43. A BMI should be less than 32. No more than 5 deliveries. No more than 2 C-section. And ideally, vaccinated for COVID. If I mentioned the cost with the donor egg being a rate-limiting step, this is even more so with the gestational carrier. Just imagine a donor egg process takes about 2 weeks. The donor gets compensated for those 2 weeks. When you're recruiting a gestational carrier, that person will be carrying a baby for 9 months, will potentially have a C-section, vacuum, forceps, multiple medical procedures and visits. So that really becomes a very expensive process. And you can see here in this pie chart that the GC compensation in light blue on the left-hand side is a small portion of that. There are legal contracts that are being involved. There are agencies that are helping recruit those donors, the treatment itself, doing the actual embryo transfer and creating the embryos, and the GC screening, all those testing that I mentioned, hepatitis B, C, HIV, saline sonogram, hysterosalpingogram, the fallopian tube test, and sometimes during a mock cycle, in most cases, those take time and resources, and usually the intended parents are the ones that are going to be carrying this cost. Utilizing a gestational carrier typically recruited through either an agency or an attorney that specializes in third-party reproduction. Some gestational carriers are self-recruited by the intended parents. It could be a friend or a family member. It has to have a legal contract because at the end of this process, there's going to be an adoption that's going to be happening. A gestational carrier is going to be delivering the baby in a hospital, and the intended parents will have to adopt and have the baby registered in their birth certificate under the intended parents, whether it's their genetic gamete, sperm and egg, or whether it's a donation via egg donor and sperm donor. The attorneys and the agencies confirm the match once the legal contract has been executed, and the gestational carriers must undergo medical and psychological screening, just like we mentioned with the egg donors. The last two slides, we'll talk about the gestational carrier screening. So let's say a patient had 2 vaginal delivery and she's willing to act as a gestational carrier. She'll have a consultation with a physician. We'll do the psychological evaluation for both her and the intended parents. We'll do the same testing infectious disease-wise, hepatitis B, C, HIV, drug screen, and then we'll do the uterine evaluation, because that's essentially the goal, right? To have a good functional uterus that's going to allow the patient to successfully carry a pregnancy and have a successful embryo transfer. And those are done with 3 procedures: a saline sonogram, a hysterosalpingogram at time, and a mock embryo transfer, which includes giving the gestational carrier estrogen pills, estrogen patch, estrogen tablets or injections to build up a thick endometrial lining. And once that lining is assessed by an ultrasound and we feel that it's a thick and a good appearance, then that embryo transfer is being mocked with essentially a soft catheter, just to make sure that it's not going to be challenging to do the actual live embryo transfer. Once the 3 procedures have essentially completed, we will mimic that protocol when we actually have the embryo to be transferred. The economics, there's some controversy around that. Obviously, it's a very expensive process, and it's not affordable treatment for all intended parents. There are ethical concerns due to socioeconomic differences between the intended parents and the gestational carrier. We don't have a good coverage through insurance, unfortunately. The cost is prohibitive for many, many couples, and increasingly, surrogacy contract requires the compensation to be placed already upfront in an escrow account, which also adds to that challenge. The safeguards that we have is that the carrier has to be over 21 years of age, healthy, stable social environment, had at least 1 delivery, ideally vaginal delivery, and then that she should have a medical insurance to allow her to get and seek medical care when needed. And then essentially the carrier should be the one who's deciding whether to transfer 1 embryo or 2 embryos. It depends on the age of the egg. If the patient is using her own eggs at age 41, we'll sometimes transfer 2 embryos to increase the chance of implantation. And as I mentioned, with donor egg and the GC, this will be a single embryo transfer in the vast majority of cases. And then make sure that the GC, the gestational carrier, has psychological support throughout those 9 months of pregnancy. The American College of OBGYN did publish a paper about the payment to the surrogate or the gestational carrier, and mentioned that if the payment is too low, it may be exploitation of that GC, and if it's too high, it may be irresistible and coercive. So there is definitely a challenge there from the intended parents' perspective to be able to afford a gestational carrier. Thank you so much for joining me today, and I hope you learn about the donor egg and the gestational carrier, and I'm happy to cover more topics in the future. Thank you so much.
Thank you so much, Dr. Singer. And now we will hear another patient story from Allison, followed by a presentation by Dr. Brian Levine.
Hi, my name is Allison, and my endometriosis journey started in July 2020 when I started to try and get pregnant. We were having a hard time getting pregnant, and I wanted to be pretty proactive about it, so I went to my gynecologist, and she suggested that I go to CCRM to Dr. Levine and get checked out, because you just never know. She said, listen, he'll take your bloods and he'll tell you when you're ovulating and you'll get pregnant. So I made my husband come with me, because I obviously thought this isn't me, there's gonna be something wrong with him. So luckily he was there with me, because Dr. Levine checked me out and he saw that I had 2 endometriomas on my right ovary. He said he couldn't be sure until I got an MRI, but he thought that that's what I had. Luckily, my husband was there with me, and I was like, what is that? I'd never heard the words endometriosis before. So I was like, what is this? I don't understand. How is this possible? So he was like, go get an MRI and we'll just confirm it or not. Sometimes it doesn't show up, but because I had the endometriomas, he figured it might. So we went, I booked an appointment to get an MRI that week. I got an MRI, it came back positive. I in fact did have 2 endometriomas on my right ovary. And at that point, I had made an appointment with an endometriosis surgeon to start the process, speak to them, see what I would need to do, see if there were any other options, and whatever it would take to get pregnant. So I went to my doctor, and they said that I would in fact need surgery, that because I had the endometriomas, it would be extremely dangerous if I did get pregnant, if I could even get pregnant. So we all kind of put our heads together with Dr. Levine and decided what our next step and best step would be. So because they were on my ovaries, we just wanted to be 1,000% safe, that nothing would happen to my ovaries or to my eggs. So we wanted to freeze my eggs right before surgery. So that way, if in my egg retrieval, we did poke some endometriosis, and I did have, some endometriomas, and I did have some leakage, that I would go into surgery soon after. So I remember, because it was election day, I went in for my egg retrieval on November 3rd or November 4th, and I got a good amount of eggs and then a good amount of embryos, which is great because now we have these embryos on ice. And I went in for my endometriosis surgery on November 12th, so about 9 days later, a week later. I did not know what I was getting myself into. I kind of went in blinders on, that's kind of my MO, and went in for about a 5-hour surgery. It turns out I did have these 2 large endometriomas, and I had another one on my other ovary. So, and I think they took out about 50 lesions. And so I was in the hospital on bed rest for about 24 hours, and then I was in bed for about a week. But honestly, I could move around. I wasn't like completely tied to my bed. I was just in a decent amount of pain, but not as bad as I thought it would be. And then I asked my surgeons that did my surgery if I could try getting pregnant 2 or 3 weeks later, because I was ovulating. I knew that I would be ovulating because I had my period during surgery, and they said, you could try, but we really recommend 6 weeks before you have sex. But if you're not that uncomfortable and you want to give it a shot, go ahead. So my husband and I tried. It was 3 weeks later, and then about couple weeks after that, I took a pregnancy test, and turns out I was pregnant with 6 embryos on ice. So when I went in for my 6-week checkup with my surgeons, they were ready to do the ultrasound. I was like, you're gonna see a little surprise when you do the ultrasound. And there was a 9-week-old little baby in there. Now I have my baby Benjamin. He's 6 months old today. And I think that if you go in the right direction, you really come up with a good game plan, there are so many options out there to get pregnant these days. That's it. That's my story.
Dr. Levine is the founding partner and practice director of CCRM in New York. He is board certified in both reproductive endocrinology and fertility and OBGYN. Dr. Levine attended NYU School of Medicine, where he currently serves as a member of the Board of Trustees. He finished residency in New York at Columbia, and then fellowship also at Weill Cornell in Manhattan. Thank you so much for coming, Dr. Levine.
Hi, my name is Dr. Brian Levine, and I'm a proud supporter of the Endometriosis Foundation of America. I'm the founding partner and practice director of CCRM New York, which is a fertility clinic in Midtown Manhattan. As someone who helps patients on their paths to parenthood, I often tackle some of the most difficult cases, those with mild, moderate, and severe endometriosis. One of the ways that we help guide patients to the best clinical outcomes is with a sampling of the lining of the uterus, also known as an endometrial biopsy. It's just one of the tools that we have to help patients understand what's not working. When we do this biopsy, we're looking for a specific protein, a protein that's known as B-cell lymphoma 6 protein, or BCL6. Elevated levels of BCL6 is associated with lower clinical pregnancy rates and live birth rates, and higher miscarriage rates, the 3 things that we hear from infertility patients. Recently published data on the treatment outcomes is helping to back up why we have this approach, why we take that extra time to figure out who our patients are, so then we can figure out what our patients need. A prospective cohort study done at a university-associated infertility clinic looked at this exact question. What they did was they evaluated the effect of surgical or medical treatment before embryo transfer in women with an elevated level of BCL6 and suspected endometriosis. To get into the study, the patients had to have an elevated level of BCL6 above a certain threshold, and they had to have a year of infertility. All of the participants underwent a biopsy of their lining during a cycle of IVF. The control group went untreated, while the others either had medical or surgical evaluation and treatment. And then what they did was they looked at the things that mattered the most: the live birth rate, the clinical pregnancy rate, the implantation rate, and the miscarriage rates between the two groups. Well, it's not surprising to learn that in women undergoing laparoscopy for endometriosis and those treated by medical suppression, they had a much higher live birth rate compared to those who had no treatment. In addition to proving out that hormonal suppression can work for certain patients, the miscarriage rate was actually lower in those treated with medical versus surgical therapies. It's important to recognize, of course, that in those who are opting for medical instead of surgical, most likely they have mild disease or moderate disease compared to the severe disease, which most likely almost always is going to be treated surgically first. But if you take all this data together and you take this one study, you start to recognize that there are many different approaches for what seems like a really tough diagnosis. And the diagnosis of endometriosis does not mean that you can't start or grow your family. Instead, the presence of this protein, BCL6, is suggestive that you need to use a scientific approach with a team of experts, people like me, to help you achieve your goal. Thank you for your time and your attention, and I hope you enjoy the rest of the wonderful presenters at this unbelievable conference. We wish you truly the best of luck, and if we can be of any support to you, please do let us know. And thank you for your gracious support.
Thank you so much, Dr. Levine. Welcome to the EndoFound Infertility Day, Dr. Amy. Dr. Amy graduated from UCLA School of Medicine and completed her residency in OBGYN at Harvard. She also completed a fellowship in reproductive endocrinology and infertility and holds also a master's in public health from the University of Michigan. She runs a very successful practice out of San Ramon, California, and has created the Tushy method and Ball's method to simplify the steps to getting a diagnosis before fertility treatment. Also known as the Egg Whisperer by a lot of our patients, she hosts the Egg Whisperer Show, which has over 40,000 subscribers on YouTube and just passed over 1 million downloads on her podcast. You can learn more about her and her practice at dramy.org. How do you, as a fertility specialist, explain endometriosis to your patients?
Well, I say things like endometriosis sucks. And it's the truth. And it can be fertility threatening. It can be aggressive. It can come back with a vengeance. And I tell patients it's also really, really common. And it's a condition that I see far too common. And at the same time, it's underdiagnosed. This is sometimes, sadly, even several fertility doctors before a patient finally gets a diagnosis. I basically tell people that endometriosis is a condition that's common. It causes pain in some people, not in everybody, and it can affect our fertility, block our fallopian tubes. It can affect implantation by annoying the uterus a little bit. But that's what fertility doctors like us and surgeons like you are here for, to help people with this common condition that unfortunately still does not have a cure.
So let's talk about egg quality and endometriosis. Does endometriosis affect egg quality itself?
Yeah. So, when I say endometriosis is fertility threatening, it has a lot to do with our eggs. And an egg, I know everyone knows this, it's basically 50% of an embryo. And if an egg isn't working, the embryo won't successfully form and it won't implant well. And then you can get things like implantation issues and miscarriages. So that's why it's so important when someone has endometriosis to really think about preserving your fertility through egg freezing or embryo freezing. It's like a catch-22, right? Imagine being told you have endometriosis, then being told, well, you have to get pregnant right away. Well, you might not be ready, number one. And at the same time, you might have a hard time getting pregnant. So you need help. And you shouldn't tell someone who has endometriosis to wait a year and try and then seek help. There's so many things that we want endometriosis patients to know when it comes to their fertility. And egg quality is one of those things, because endometriosis can decrease the number of mature eggs you can get. It can make the age of someone who has endometriosis, their egg age, act chronologically older than their chronological age. I should call that the egg age versus chronological age. It might be increased. It can potentially affect your AMH level. It can increase the rate of something called aneuploidy or genetic abnormalities in the embryo as well. And then you also talked about the annoying endometriosis effect of implantation in the uterus too, when it comes to adenomyosis. And if people wait too long to get pregnant, even if their egg quality is good, if the uterus is not as favorable, then you might have, issues with that. So yeah, endometriosis definitely affects egg quality. And one of the things that I do is I have patients see someone like you.
So how do you counsel patients as far as diet? I know we talk a lot in the endo world about low inflammatory diet for autoimmune disease and endo and inflammatory conditions. Does the same apply for fertility?
Absolutely. I want my patients to be as lean and mean as they possibly can be when it comes to endometriosis. And it's not so much about losing weight, it's about building muscle and reducing the amount of fat on your bones, because we know that fat is inflammatory. Fat cells equals higher estrogen in the body, and you hear things like estrogen dominant. So women who are a little bit on the curvier side, so to speak, might have more estrogen. And we know that women who, let's say, exercise feel better and actually might have less pain with their periods. If they're exercising, that they feel better, their endo symptoms are not as bad. And I think as soon as you're told that you're going to be a fertility patient, all of a sudden things slow down. You feel like you can't lift a finger and you shouldn't work out. And I tell my patients the opposite. I say, please work out as much as you can and build muscle, because that can help decrease inflammation in your body. It may improve. I don't like to use the word improve. I like to use the word support your egg quality that you have.
How about autoimmune dysfunction? It's been shown to be connected to endometriosis. Do you recommend any particular testing for patients for immunologic disorders? How do you counsel patients on what tests to run, who to see about this, and what should we really be, working on?
Yeah, patients have access to so much information online, and they, like you said earlier, they can become their own experts in a way, especially when it comes to reproductive immunology. And I ask patients to read certain things, and then I ask them, does this resonate with you? Do you feel like this might be an issue for you based on what you've read? And if the answer is yes, and they want to do the testing doesn't hurt anybody. And when you test a whole bunch of things, you're probably going to get a few things that are positive. It doesn't necessarily mean you have something terribly wrong. And then we can use our brains and talk to people and figure out what makes the most sense given their history as to what the right approach should be. And for some people, it could mean supplements. It could mean I actually add aspirin into every one of my transfer protocols unless someone's allergic to it or has some other contraindication to taking aspirin, like, reflux or something like that. I do use short-term steroids up until transfer day. And I also use Lovenox in certain situations. I've always done that. But they're not for everybody. There are other things that people have heard about, like IVIG, intralipids. I don't necessarily start with those things. If there's a reproductive immunologist that thinks my patient needs them, I will support my patient with that and order them as needed. But I really don't expect that I would be the expert in this for my patients. And I always refer them to a reproductive immunologist, endometriosis specialist like you, for example.
We know obviously that anti-Mullerian hormone, or this fertility hormone we call AMH, it declines with age, and it's a marker of the primordial small follicles that are there that can produce eggs in the ovary. Does suppressing AMH or anti-Mullerian hormone have a permanent effect on endometriosis? And how do you approach patients with so-called diminished ovarian reserve or low AMH and endometriosis?
Yeah, so I think it's important to know what your AMH is at baseline, because if your AMH is already low and then you're suppressing your AMH with, let's say, a medication like Depo-Lupron or Orlissa, and then you go back and check your AMH afterwards and it's low and you didn't know it was low at the beginning, you're going to think that Depo-Lupron suppressed it and caused you to go into a perimenopause or menopause. But these medications do suppress AMH. It's almost always reversed with just a little bit more time. And I have a patient I'll never forget, and this is where I really learned it. Her AMH was almost 2, and then I put her on Depo-Lupron. Her AMH dropped to like 0.1, and I was freaking out. I was like, oh my God, this is nuts. How did this happen? But it was just temporary. I was like, Amy, chill out. And then we just waited, but I'd never seen such a drop. It was my first experience like that. This was years ago. And now I just tell people, we're not checking your AMH right after Depo-Lupron. That's not a good idea, because it'll just give you a slight heart attack. But the reality is that, these medications can help. I think it's important to think about your fertility and know your numbers before you choose these options, so that if you want to preserve your fertility, consider doing it first. But there are patients who need these medications before surgery for different reasons, and then they stay suppressed before an IVF cycle or an egg freeze. And these are conversations that you and I will have before they even do surgery, so patients feel like they had all their options up front before they decided what was best for them.
I know we talk a lot about letrozole, or a drug called letrozole or Femera that can keep estrogen low. It's very hard, obviously, to balance keeping the estrogen low like you do for breast cancer patients, but also getting the right amount of eggs and ovaries that are already having trouble, and then, not stimulating the disease or making the patient feel terrible, obviously. So how do you balance that in these patients?
Yeah, I don't like birth control pills. People use birth control pills to coordinate IVF cycles. And in some patients, it might be helpful. Patients who have, let's say, a really high number of eggs to prevent ovarian hyperstimulation syndrome. But most of my patients are coming to me because they're in a situation where they have a lower number of eggs. And we know that birth control pills can equal a lower number of mature eggs and a lower number of eggs in general. So that's why I try and stay away from them a lot. And in endometriosis patients as well. I use letrozole in almost all my cycles, especially for endometriosis patients. And I use it to keep the estrogen down. The eggs still grow, and people are like, my estrogen's so low. I'm like, yes, it's so low. It's what we wanted. And they're like, but it's so low. And I read online that each mature egg is supposed to secrete 100 units of estrogen and be mature. And now my estrogen level is only 150. I'm like, no, we're good. I did this on purpose to protect you. But if you're, I tell my patients this stuff up front, that when I check your first estradiol level after 5 days of stim, your estradiol level is going to be 20, and that's what I want. And I either do a Femera flare, so it's 5 days of Femera, or I'll do Femera the entire cycle. It just kind of depends. If someone has really severe endometriosis, I'll even continue the Femera past the egg retrieval, just to make sure even after the trigger shot, the estrogen level isn't changing and going up. And I want to bring it down as soon as possible. And sometimes I'll even use an antagonist like ganirelix after the egg retrieval as well in those patients. And sometimes I'll even start birth control pills right after the egg retrieval to prevent my endometriosis patients from having a period. And even in a few cases, I've even started them on Orlissa right after the egg retrieval as well, because I've seen patients with such bad endometriosis that periods are like a complete nightmare. And sometimes after an egg retrieval, that period can almost be, dangerous, because I tell people sometimes it can feel like a waterfall. And for someone who has really severe adeno, that waterfall could be a pretty scary one. Maybe like, in relative terms to what you're used to after an egg retrieval, it could be like Niagara Falls. So I don't want people calling me, I'm in the ER because of my period, right? After an egg retrieval. I want people to call me and be like, Amy, I'm so glad you did all this for me, because my period is not the nightmare that it usually is. Thank you so much. So yeah, I think suppression is not something that I do. Femera flare or Femera throughout to prevent worsening of endometriosis during the cycle is really important to me. And especially in patients who might be doing multiple cycles, that's something that I also do, is make sure that, the Femera or letrozole is there throughout. And I'm very conscious about the amount of meds that I use. I try to maximize the number of mature eggs I get from each cycle. And I do that with the right amount of medication. I don't just automatically put everyone on a certain protocol. Everyone's protocol is individualized to them.
What do you think about mini IVF? What do you think about natural IVF?
So when it comes to mini IVF, I always say I want to get the maximum number of eggs using the lowest amount of stim. There's no such thing as less is more when you have more. So the more eggs we get, the more chances. But if you have less, stimulating with more isn't going to turn the less into more. And I sound like a Dr. Seuss book when I say this. But that's the reality, is that more is going to be more when you have more. And then you have to get more doesn't mean that you're going to get better. And so that there's, obviously it would make complete sense that the 2 eggs that lead the pack are going to be the best quality eggs. But that's not how fertility works. When you ovulate an egg, your body doesn't know which one's a good one and which one isn't. But I think people think that that should be the case. So I've heard other doctors say to patients, through what patients tell me, that, oh yeah, the less eggs you get, the better the quality of the one that you're going to get. I'm like, no, that's actually not true. I wish that was the case. I wish, but I want to, get as many eggs as I can as safely as possible for people, so I don't have to do more cycles also. So if someone, let's say, has 10 follicles and I'm getting 2 eggs versus 10 follicles and I'm getting 10 eggs, getting 2 eggs for the patient with 10 isn't going to give her a better chance than getting 10. 10 is going to give her a better chance of having her fertility preserved than getting 2 from the 10. But there are patients that tell me, Amy, I just don't want a lot of drugs. I just want to get 2 eggs. I don't want to feel, bloated, and I'll be fine with 2. And that's fine as well. But it's just important for people to know, practically speaking, what would give them the best chance of pregnancy and the dose that would do that. And then they can choose if they want to go lower or higher based on what their goals are.
What do you think about PGS testing? Are you very pro genetic testing of embryos ahead of time? We have a lot of patients that come and they talk about mosaics or embryos being discarded or potentially the biopsy hurting the embryo.
So my thoughts are, embryo testing, I think, is really important. I think it's a great technology, but it's hard to do. It's very expensive. It takes a lot of training in the lab. You have to have a really skilled, think of it like as a pediatric surgeon. Not everyone's the same at doing surgery on a child. And you have an embryo that's microscopic, not anyone can do it. And so if someone's telling you, oh, you could damage your embryo if you're doing genetic testing in this lab, don't do it. Listen to them. And people are really stretched thin right now with the pandemic. And so I feel like if it might be safer for people not to do genetic testing in certain labs because they don't have the special lab technicians called embryologists that can perform this biopsy safely. And I've seen a lot of things happen to embryos around the world. And just because someone wanted to do something that they thought was good for them, it turned out being not good for them because of, let's say, biopsying the embryo at an unsafe stage. For example, biopsying the embryo when it's a morula. That can really destroy the embryo. Or biopsying the embryo when it's an early blast. Or biopsying a very, very poor quality embryo just to do the biopsy to get genetic testing. Like, that makes no sense, right? So that will destroy an embryo. We do genetic testing on over 90% of our cases because we have the top 5% of embryologists in the world here in the Bay Area. And so we're very lucky to have that. And I do a lot of things that are creative with people. Like, for example, today I did a transfer of one embryo and I'm freezing and testing the rest. So she has a chance for a pregnancy right now without waiting, which is awesome. And then we'll know what we're going to have frozen for her in the future. But she's lucky because she had over 5 blastocysts today. There are some people who have just 1. And I actually think when you have just 1, it's very important to test that embryo in certain situations because you want to know if it's normal or not, so you can know how many more cycles you should be doing. And if you have something like endometriosis, sometimes you might need someone else to carry your pregnancy for you. And that other person, it might be really heartbreaking to transfer an embryo that's genetically abnormal and have to deal with that after everything else you've been through. So transparency is super important. I have all these little phrases and sayings that I tell people. One of them is, it's called embryo diamonds. Diamonds is basically the day your embryo was biopsied and frozen, the implantation rate, whether it's abnormal, whether it's mosaic, whether it's normal, those are all the things. Just go to embryodiamonds.com and you'll read about it. But basically it's important to know all that stuff ahead of time, not after the fact. For example, after the fact, finding out that your lab won't tell if your embryo is mosaic or they'll automatically discard your abnormals, that's not fair. You got to know that up front. And you got to really look at the fine print because you may not have options.
The CoQ10, just a quick question about that. A lot of patients have is how much do they need to be taking?
And when it comes to supplements, I say less is more. You can get a lot of the stuff from even the foods that you eat. And I tell patients to take, one of the Theralogics CoQ10, it's 125 milligrams or so on the bottle, but it's equivalent to close to 700 milligrams of CoQ10 because of the Vesisorb that it's made with. And so you don't need, let's say, 4 to 6 of the Theralogics brand. You can just take 1 to 2. If you take a different brand, maybe 300 to 600 milligrams of CoQ10, if it doesn't have that Vesisorb in it, would be good for you. I think CoQ10 is probably one of the most important supplements that patients should take. And I think every young person, every person in their 20s who might want to have kids should start taking CoQ10 because it's not necessarily something that, snap your finger, it's going to support your egg quality right away. It might be something that over 6 years, it might help your egg quality, not, 2 months before your IVF cycle. But I put every egg freezer, every egg donor, every IVF patient on it. Even my egg donors, I have them take CoQ10 during their cycle.
Nice. Yeah. Even 20-something-year-olds that are egg donors, you would do. Yeah.
Yep. And all my egg freezers, I say, get on CoQ10 as soon as I do that new egg freezing consult. I say, and don't stop it until you're done having kids.
Of course, there's always a balance. So, is there anything else you'd like to add for patients with endometriosis or patients maybe that suspect they might have endometriosis but haven't been diagnosed?
Yeah, when it comes to endometriosis, I want to tell people to keep asking questions, okay? And don't forget how precious your own DNA is. And don't just roll your embryos like rolling dice. So be very thoughtful about what you do, how you do it, when you do it. And if you need to take time to kind of think about it, there's no emergency. There's never an embryo emergency, right? And once you transfer an embryo, you can never get it back. So if you need to meet with multiple IVF doctors to figure out the right plan for you, do that. If you need to get more than one surgical opinion before you pick the best surgeon, before you do your surgery, before you transfer, do that. And, that's probably the one thing that I think endometriosis patients should know, because I see sometimes people feel like they made a decision and they didn't have all the information that they needed before they did what they did. And maybe if they had more information and then they regret it later.
Where can people find you or find more information?
So people can find me on dramy.org. I run an IVF class once a month. I call it a master class, actually, eggwhisperschool.com. You can find me on YouTube. Anywhere you listen to podcasts, you can tune in. I also have a series called Ask the Egg Whisperer. You can go to asktheeggwhisperer.com and put in a question. And at some point, I'll get to all of them.
We really appreciate you being here. Today, this is really a day truly for patients and for their questions and their knowledge that we're trying to push forward from both the practice, but also EndoFound. And we're excited about this opportunity.
Thank you, Carly.
Thank you so much for coming. Thank you so much, Dr. Amy. Now it is my pleasure to introduce Hallie Terrell, a licensed clinical social worker and the founder of Travel Light Now, a therapeutic practice that specializes in women's health. Her specializations include mental health, life transitions, relationship coaching, fertility journey, and endometriosis support. She supports women in individual therapy sessions as well as sister circle support groups, meditation, yoga, and navigating through their resources. Her postgraduate fellowship in clinical social work was completed at Yale, and she also obtained certifications as a board-certified holistic health coach, life coach, yoga teacher, embodied dance teacher, and Reiki master. Welcome, Hallie. Thanks for joining us today.
Hi everyone, my name is Hallie Terrell. I'm grateful to be here to share a part of my journey, as well as offer you some guidance in this very complicated world of fertility and endometriosis from the perspective of a licensed clinical social worker. There is a lot that I could share with you about my story. However, my desire here today is to provide you with as much support and information as I can. I will be including my contact information within my bio, so you're more than welcome to reach out to me if you have any questions or would like to meet with me one-on-one. My story first begins at the age of 11, when I first started experiencing symptoms of endometriosis. But at that time, I thought this was the norm. I went through 29 years of suffering with endo and having it dismissed by numerous doctors. As research has shown, so many of us face incorrect diagnoses. I was diagnosed with irritable bowel syndrome, interstitial cystitis, hip misalignment, growing pains as a kid. These are just a few of what I heard. And due to this, I turned inward and worried that I was overreacting and that nothing was actually wrong with me. It was all in my head, and therefore I was a hypochondriac and dramatic. In my late 20s, I decided it must be due to gluten and dairy. Yet every time I took it out of my diet, the pain would persist and sometimes get worse even. I continued the process of changing up my diets for years with no results, to the point that I ended up questioning everything I ate, everything I put on my skin or used to clean the house, because it was like, what if something in that is toxic, and what if that's causing the pain? Because I had no answers. I even became a health coach as a result of this. It wasn't until I was dealing with unexplained infertility in my 30s that things started to come together slowly. I didn't even know that unexplained infertility could be explained. I thought that unexplained fertility was my answer. My husband and I went through 8 rounds of fertility treatments before finally understanding that the reason that I was struggling to get pregnant naturally or with fertility treatments was because of my undiagnosed endometriosis. Throughout the course of my 8 fertility treatments, I began to advocate for myself and wondered if endo could have been the cause, but I didn't start advocating or questioning about endo until the 5th or 6th cycle. I was told that even if my problems were endo related, that IVF would bypass them, and that even after I advocated during a painful transvaginal ultrasound, I was told it's got to be muscular. And then I was questioned about how I was managing my anxiety. That was really uncomfortable, to be once again in the position of thinking I was too much. After a miscarriage, I again questioned endometriosis, and I was told that the cause of the miscarriage was poor embryo quality. Poor embryo quality. We didn't test our embryo before transfer, so again, we were left with the unknowns. Was this true, or was there something else playing a part here? Or were we just not destined to be parents? This was when we broke up with our first fertility doctor. The thought of starting with someone new was daunting, to say the least. That's why we stayed for 6 rounds. After 2 more procedures with 2 more doctors in the same practice, we were completely unheard and scared. At that time, COVID happened, and I took to finding a doctor like it was my full-time job. It literally was. This is what so many of us face, that there's so much to organize and so much to figure out. And unfortunately, most often we don't have the time, or we don't even understand what we're supposed to be looking for. But keep questioning. If you believe there's something going wrong, don't be afraid to advocate for yourself. Find those answers. Throughout my journey, I learned a lot of things regarding infertility from the standpoint of a licensed clinical social worker. One of the main things is that there's a huge stigma regarding fertility and endometriosis. Everyone's struggling but discouraged against talking about it. This leads to us having to deal with this solely on our own. I noticed once in the waiting room, and then time and time after, that people don't talk to each other. We don't even look at each other. It was silent. It's a known thing that we're all afraid to meet another person going through this because it's all too scary to hear about their success or loss. So we just avoid talking or looking. But one time a couple walked in and the partner was crying, and I decided to break the silence. I asked if she was okay. She told me it was her retrieval day and she was petrified. I told her it was my retrieval day 2 days after that, and I also was scared. We started to talk from that point on. We were listening and understanding each other. At that point, I knew how important it was for people to get together and talk. I asked my fertility doctor if they could start a fertility support group, and they said no. Other places did. At that moment, I knew my path would be to incorporate this in my practice as a licensed clinical social worker. People do not need to be alone in this. It's important to feel seen and heard, and a sense of belonging means more than anything on this journey. At least to me, it does. We learned together on 3 more cycles together as new friends. My husband had someone to talk to. Her husband and my husband became friends. They started to talk about what it was like for them. They would call each other on the phone. They would get together with each other. And this was really, really important as well, because so much of the time our partners are left out and they're the caretakers. And honestly, that's sometimes one of the hardest positions in this entire experience. It's like they can't do anything to help us when the things are getting really difficult. Make sure your medical team is there to benefit you. We continued with this doctor for 6 cycles because we were afraid to start over. We were worried that it would be easier to stay with him versus starting with someone else, because we were also told that you needed to get to be known through all the cycles. So why would we want to start doing that with someone else? We felt like a number with our second doctor. We walked into our consult. We were given 2 options: either adopt and be 100% parents, or get a donor egg and be 70 to 80% parents as a chance to be a parent. It was so discouraging. It felt terrible. No questions were even asked. We weren't even people. At that time, though, we were willing to sacrifice being treated poorly for a doctor that knew what they were doing, because we were told that this doctor was like a bulldog and got stuff done, and our numbers and our counts were low, so we needed to hurry up. It might be scary to change practices and find new doctors, but do what's best for you on your journey. Finding a doctor who will listen to you and see you as a whole person and not another patient is very important. I can think back to myself wondering when I was younger about what was wrong with me. And when I started to be able to advocate for myself and my family, it started to feel better. The day I received my endometriosis diagnosis, I knew that everything was going to be okay. I was interviewing doctors at that point, and I found our final fertility doctor. At that point, I had developed a fertility question checklist. I'm happy to share it with you. It's long. I wanted to make sure that my doctor knew about endometriosis, knew about autoimmune conditions, because I was looking into that at that time. And if he didn't, that he would refer me to someone that could. He did all this and more. He listened to us, he made us feel seen and heard, and he spent ample time with us over the upcoming months prior to my surgery for endometriosis. In therapy sessions, you can role play with your therapist. You can decide what you want from your doctors and create your own question checklist, or of course you can borrow mine or have it. 2 months before we saw our final fertility doctor, I had surgery for endometriosis, and we had success with our surgeon, and we had success with our fertility doctor. Additional recommendations that I find important are to build your support team. This could be your doctors and therapists, friends and family, and other sources. Some other sources might be naturopaths, acupuncturists, pelvic floor specialists, to name a few. But reaching out to a therapist can be really intimidating, but I can assure you it's one of the most beneficial tools for you in this journey. You don't have to be on your own. Meditations and mindfulness exercises are methods that a therapist can incorporate too, to give you something to work on and to use outside of the therapy sessions. They can help you find your voice and advocate for what you need. It took me the 2 full years of my beginnings of fertility to know how much my mental health was impacted. It took me that long to even know how to ask a therapist for help, even though I was one. Some fertility offices have social workers on staff and support groups. However, they're solely focused on fertility. I recommend being treated for your whole self, which allows breaks from the details and stress and pain related to these conditions. There are multiple different types of therapy you could pursue. There's individual therapy, group therapy, process groups, as well as couples therapy. You can also find support online through support groups, social media platforms, and things like that. Personally, I work one-on-one with people, and I run circle support groups, and I do this virtually. It can be hard to find the right therapist, and it took me a lot of time. For me, my fertility doctor gave me the name of one therapist, my first fertility doctor, and this person didn't take my insurance, and it would have to be out of pocket, which was really, really hard. Later on our journey, when I still was looking for an individual therapist, my husband and I needed the support of a couples therapist. This was easier to find for some reason, and we needed this support to help navigate our decisions about moving forward with additional fertility treatments, and it really, really helped us. I feel that therapists can have all the training in the world and say that they understand infertility and endometriosis, but I think it's very important that the therapists themselves have this experience. Self-disclosure in sessions is a newer practice for therapists, and I've been doing that. I've been telling people that I've been through infertility and I have endometriosis. Of course, I keep my professional boundaries in order to have the therapeutic relationship, But one thing that finally worked when I found my individual therapist was that she told me she had gone through infertility and she had something called polycystic ovarian syndrome. And I knew I was going to be heard, and I just wasn't another client or patient for her. I'm always happy if you want to reach out to me to help you find a therapist. Some ways to find a therapist are asking your doctors, your primary care doctor, word of mouth, and psychologytoday.com tends to be the best place. You could put in the location you want to be in if you want in-person sessions. You can spread out your location if you want telehealth. Most sessions now are available on telehealth. That's what I offer. And I find it to be best for me as well as a patient. I recommend calling your insurance company to know what your benefits are. It's really important. There are different types of therapists out there, like licensed clinical social workers, psychologists, marriage and family therapists, licensed professional counselors, and many, many more. I recommend asking for a free consultation. Not everyone does that, but it is really important to ask for it. I always have a free consultation with the people that connect with me. It gives us a time to answer questions and discuss, and also see if we're a good fit. And if we're not, for whatever reason that might be, I always make sure to have other people to refer them to. In terms of a personal support team, it's important to have someone confide in. It might be someone that you too meet in the fertility office or the endometriosis office. You want to have someone that you can cry with. Some of the most important moments for me was when my close friend would say to me, "This really sucks. This is horrible. I can't believe you're still going through this," and just made me feel good and validated that it really was the hardest thing I ever went through. You maybe want an adventure friend who will come over and cheer you up and take you out on walks, know when you're really down in the dumps and wants to come out and be with you. Or a friend that's not even going to talk to you about your struggles and just have a person to be with. But taking breaks away from it all is really important. Even a therapy pet is really nice to have if you could do that, if that's an interest of yours. Some people might need to continue working through all this stuff, or might need to be home. Know what your policies are at work, what you can do, and see what you need. Movement's really important. We're always told exercise, don't exercise through all that. It's so confusing. Do what feels best on your body. Even if it's just 5 minutes a day, get your blood flowing and get yourself moving. When we're feeling sad, I find that most of the time stepping outside of the four walls of my house and going into nature gives me the reprieve, but also the break from it all. And I always feel better after. Online meditations are great. I love the Insight Timer app. I will go ahead and tell you that Yoga Nidra, which is called sleeping yoga, is one of my most favorite things to do. You just have to lay there the whole time and be guided. Breath work is really important. You can find all that on YouTube. Some of my favorite breaths are box breath and alternate nostril breathing. But don't feel pressured by what you think you need to do on your journey, because it's your journey. Don't let anyone force you to move to the next cycle. Don't feel that you need to be stuck with doctors, and make sure you keep saying what you need till you find your answers. It's important to be held and listened and to belong. I'm so grateful I got to be here with you tonight. Please reach out to me at any point. I will go ahead and include some more information in my bio. Have a great day.
Thank you so much, Hallie, and thanks for offering to be a resource for patients. Now it's my pleasure to introduce Jessica Murnane. She is an author, speaker, a creative consultant of many things. Jessica has written 2 books, the cookbook One Part Plant, which is a simple guide to eating real one meal at a time, and Know Your Endo, an empowering guide to health and hope with endometriosis, which she let me help on, which was fantastic. She's a sought-after speaker and a host that's spoken at Apple, South by Southwest, Wanderlust, Charleston Wine and Food, and many other places. She has contributed to and appeared in several magazines and websites, including Bon Appetit, Goop, Shape, Kitchen, Mind Body Green, and The Coveteur. Take it away, Jessica. Thank you.
Why did I choose adoption for my family? So it's kind of crazy, but from a very, very young age, and I'm talking middle school, high school, I knew that I did not want pregnancy for my body. I have no idea why. I just knew it in my bones that I did not want to experience pregnancy. And at the time, I wasn't diagnosed with endo. So I always think, did my body know something before I did? Did I have these endo angels planting the seed in my brain? I'm not really sure, but adoption was always my first choice to create my family. And I'm not gonna cry, but I'll have to tell you, adoption is one of the coolest things that I've ever done in my entire life. And I'm so glad that that's how I created my family. What was the process like? So I think the biggest thing to know about the process is that it is not what you see in Lifetime movies. It is not what you see in the media. I think that in the media and in Lifetime movies, they make the process seem incredibly scary, incredibly long, incredibly emotional. And while it can sometimes be emotional, and while it can sometimes feel long, it's usually not what you see. And for us, the process, I thought it was kind of fun. I got to really connect with my husband in a much deeper way about why we wanted to create a family. I got to really think about how I wanted to be a mom. I got to think about the process, and the process just made it even more clear how much I did want a family. So yeah, I mean, every state is going to be a little bit different. Every agency is going to be a little bit different, but there's paperwork, there's a home study, there's classes, and it can be a really beautiful experience and not the scary one that you often see. What advice would I give to someone that's about to adopt or considering it? I have to say, I think the most important thing is to find positive adoption stories and to talk to a friend of a friend that has adopted. I mean, at least once a month, I talk to a friend of a friend who is thinking about adopting, but is freaked out about it and they're not really sure what to do. And just them being able to talk to someone that has been through the experience, has had a positive outcome from it, can change everything. I think the last thing you want to do is get online and go down the rabbit hole of worst case scenarios, because there's a worst case scenario for everything. I think with endo, we live a lot sometimes in worst case scenarios, but adoption can be one of the most beautiful, amazing experiences of your life. I am crying. Thanks.
Thank you so much, Jessica. And everyone can check out her books if you want more resources on those. Next, it's my pleasure to introduce a dear friend, Lida Amati, who is an acupuncturist, completed 4 years in Chinese medicine and traditional Oriental medicine at Pacific College in New York. She also is board certified Chinese medicine herbalist and completed clinical training at NYU Hospital for Joint Disease. She has many years of experience using TCM to help women with their cycles, endometriosis, and many other things. She is joined today by her husband, Junod, who is a hypnosis specialist, among many other things. And Junod specializes in being able to talk clients through all sorts of issues with anxiety, with pain, addiction to different things, or just empowering them on their journey and whatever it is they want to accomplish in their life. Thank you so much for the power couple for being here today.
I'm Junod Etienne, clinical hypnotherapist and mind coach. And I want to talk to you today about hypnosis and fertility. If you're trying to have a baby, are you addressing the mind-body connection in your plan to conceive? The mind-body connection. The body affects the mind affects the body. It's pretty well documented that infertility causes stress, that the idea of not being able to willingly conceive a child can result in social and emotional pressures on a couple. Studies also show us that the reverse is true, that stress, anxiety, and depression are causes and exacerbators of infertility. There's clear data that shows that the more stress, anxiety, and depression a woman experiences prior to or at the beginning of an IVF cycle, the less likely she is to get pregnant. So while we're still discovering so much about this mind-body connection, it's becoming clear that it's quite powerful and that we can use it. An interesting phenomenon is that women will often become pregnant at the very point that they stop trying so hard. You might have heard stories about women who tried for years to have a baby and then gave up and adopted a baby, only to quickly find themselves pregnant. My own sister was one such woman, and my wonderful niece, Elise, is a product of that experience. This is a great example because it suggests that by loving and caring for a child, being able to relax into the idea of being a mother, something happens in the mind-body connection that then allowed conception to occur. So how do we use this? How do we initiate this kind of response in the body? Hypnosis is the natural communication with an individual's subconscious mind. And since so much of the stress response and the tendency to experience anxiety is subconscious, hypnotherapy is a powerful tool to help dissolve states of stress, anxiety, and even depression. It's a powerful way to resolve inner contradictions and hidden negative attitudes. So sometimes what lies underneath the beautiful desire to have a baby is fear. Fear of pregnancy, fear of labor, or fear of being unprepared for motherhood. These conflicting emotions can be totally subconscious or unknown to the woman who's having them. And they can transform into a form of stress that actually affects her physiologically, negatively impacting fertility. Often, in working with women in a session, I'll discover that they have one or more of these fears. And that's very surprising to them at that moment, even shocking. But it's okay, I tell them. We can clear and transform these inner conflicts. Now, when I work with clients, in addition to doing hypnosis, I teach them to process their stress, to manage their emotional world using techniques of breathing, mindfulness, and progressive relaxation. Through repetition and practice, they're able to restore a more calm and centered internal stance, freeing themselves from the stress of compulsive worry and doubt. This kind of learning happens on a deep subconscious level, restoring a greater sense of well-being and a clearer problem solving to various areas of their life. And because of the mind-body connection and how powerful it is, the new mental and emotional stance shows up in every area of life, including in the body's functioning. Whether your goal is to try to conceive naturally or to work with assistive reproductive methods, addressing the subconscious mind and the mind-body connection is key to success. This is why hypnosis and the mind-body techniques that I work with are an excellent complementary modality for treating infertility. Thank you.
Hello, everyone. My name is Lida Ahmadi, and I am a traditional Chinese medical practitioner. I work with acupuncture and Chinese herbs, nutritional guidance, and other modalities based on each patient's case. I've been working with women struggling with fertility for over 20 years, and it gives me great pleasure to support and guide women to have healthy conception and pregnancy. I see a lot of endometriosis with my patients. Some are very advanced and severe endo, as well as some milder cases that will cause issues with healthy conception and fertility. Endometriosis can cause implantation problems as well as interfere with pregnancy, sometimes causing recurrent miscarriages. This I often see in clinic. Because endometriosis is not always present with symptoms, it is often not properly diagnosed. But what is great about Chinese medicine and acupuncture is that we focus to balance the body's whole systems and treat the root cause of any imbalance. And because of that, we can really support most patients who have fertility trouble due to endometriosis or otherwise. I have a lot of women coming to me at different stages of their fertility journey. And sometimes the unsuccessful attempts to get pregnant leave people really disheartened, weak, and stressed. Most people, when they're in this state, find it really difficult to have clarity about what they need and how to support themselves. My treatments are geared to really calm their nervous system, also boost the immune system, and promote circulation and energy, which will counter the issues that they're having with fertility. In China, Chinese medicine is used alongside Western medicine to treat all types of gynecological problems. I myself am a big proponent of a combined approach to help women achieve health and wellness quickly and efficiently. This is especially true for modern women who find themselves ready to have a family later in their late 30s and 40s. Early detection and education for women about endometriosis is extremely important. Successful removal of diseased and inflamed tissue from their body through surgery is an effective treatment for endo. And when it's combined with acupuncture and herbal medicine, it can truly result in miraculous recovery for many patients. I have witnessed this many times. And when I work with my patients, I truly encourage my patients to slow down, really support their bodies, to take care of themselves, to nurture both their mind, body, and spirit, so they can feel calmer, they can feel more confident and stronger. I'll tell you a story of a woman that recently came to me who suffered through 5 miscarriages in total. She and her husband had been trying to conceive for 3 years. 2 of these miscarriages were from natural pregnancies, and the other 3 were from IVF fertility treatments. By the time she came to me, she was so overwhelmed and disappointed. It was almost as if she really needed some relief from all the pressure of trying to make a pregnancy happen. She was having sleep issues, she was having digestive issues, and her cycles had become extremely irregular and even more painful because of the side effects of the fertility treatments. Unlike the other professionals who were going with a particular direction, I began treating her with a different intention. I knew I had to first restore her health and balance before doing anything else, because I was really concerned about her safety and her health, future health. I asked her to become my partner in nursing her mind, body, spirit back to health and pause on fertility work. It was definitely draining her, and she was really feeling it and sensing it. After a few months of weekly treatments, all her physical and emotional symptoms became much more stable. She was sleeping better, her digestive system kicked in again, she felt stronger. She also had some real mental clarity, which helped her make some life decisions that supported her fertility. This is not a unique story. Many of my patients come to me with similar experiences. I'm happy to report that this patient conceived a healthy pregnancy and is now nursing her beautiful baby with an abundant supply of mother's milk, which in Chinese medicine signifies the body's operating in a state of vitality. I also want to share with you this unintentional pressure that women often receive from their fertility specialists to jumpstart fertility treatments, even though there are unresolved health issues. I find that the focus on numbers and treatment strategies can be harmful if it doesn't take into account the basic integrity of the body, of a person's body and state of health. It's almost like taking a gamble. And that sometimes works out for women who are younger and stronger. But for women who need more support, this can prolong their effort to conceive, as well as cause some major weakness in both their health and well-being. I think things have changed a lot in the past decade. I feel and notice that more women are learning to incorporate natural methods like acupuncture, Chinese herbs, nutrition, yoga, meditation, everything to support themselves to prepare for a healthier pregnancy and to do it in an empowering state. And this will make a huge difference, especially for patients with endometriosis. Thank you so much. It is really my pleasure to be a part of this great conference on endometriosis. I want to thank Dr. Goldstein and Dr. Seskin for their incredible commitment to providing support for women. Endo is a health challenge, but it does not need to define who we are. Powerful, resourceful beings, capable of loving and nurturing ourselves and having answers.
Hello, everyone, and thank you so much for staying tuned. We'll take a 2-second stretching break. I just need to make sure if our last person is coming, or we're going to move straight to the Q&A. So this is the 7th inning stretch here. And
Okay, so we will move straight on to the Q&A, and we're just going to notify everyone now. And Jean and Sarper, if you guys are technological crew, Jean, Andrew, Sarper, thank you so much for all your help. You've been immensely helpful. We are going to get everyone on board, a little change of schedule, and try to have everyone on right now for the Q&A. We have lots of questions submitted by everyone. And let me get this going. Dr. Levine, we have you here too?
Hi.
Hi, great. Okay. Thank you for being last minute on. Dr. Suchkin, are you back on? He's hooking up. Okay. Diana, I put the list there as well. If you want to start with one of the first little group of questions, maybe Dr. Levine can get us started as we get everyone rolling in.
So this one hits home because I had no idea what it was when I first had this blood test. It's called the AMH, and someone is asking, what is the anti-Müllerian hormone?
Sure. So AMH is a hormone that's made by the smallest little follicles in the exterior aspect of the ovary. So as we heard in one of the lectures this morning, on the outside of the ovaries where we have that cortex where all the follicles are developing and the eggs are growing. And so AMH is one of the ways that we have the ability to check how much gas is in the tank. What is someone's ovarian reserve? Unfortunately, many people put a lot of weight into AMH as the be-all, end-all. And as we know, patients are more than just a single number, and patients are more than just a single blood test. So if your AMH score is very high or very low, or is confusing to you or your practitioner, I would say make sure you go to a fertility doctor to get a proper evaluation. But AMH is just one of the tests that we do to take a look at someone's ovarian reserve.
The follow-up to that question is, when should someone who has been diagnosed with endometriosis get their AMH checked?
Immediately. So everyone's AMH is going to be different. But what we do know is that endometriosis is a destructive disease. Unfortunately, it's a disease that, if left alone, will wreak havoc with someone's fertility. As such, you want to know, what does someone look like? What do they look like over a period of time? And you can't draw a line unless you have at least 2 points of reference. So if you have the diagnosis of endometriosis and you're knowing what to do next, and AMH is an excellent way to say, let me assess my fertility and at least understand today what my ovarian reserve looks like.
When should someone freeze their eggs? That's the question. When would it be wise to do that?
So egg freezing is a rather new technology, and many patients are unaware of that. Egg freezing became advisable and no longer experimental, according to the American Society for Reproductive Medicine in 2012. Since that time, we've seen a rush of patients coming in to freeze their eggs because, truthfully, it's the only way that someone can protect and preserve their fertility. With that said, freezing your eggs is a decision that you make in consult with a reproductive endocrinologist or an infertility specialist. You have to have the conversation about when to freeze your eggs and why you're freezing your eggs. Quite often, we'll share patients with Dr. Suchkin and Dr. Goldstein, and we'll have the conversation of maybe they need to be surgically optimized first before freezing their eggs. Or maybe sometimes we freeze our eggs before doing surgery. And that's what's really important. It's important to have a holistic approach where you work with your practitioners from multiple teams to make the best plan for each patient.
You mentioned something about optimizing with surgery. So which infertility patients need surgery? How do you decipher that?
So the decision for surgical or medical therapy is a complicated one. My advice is always that if I see a patient where I'm unsure of what the next step should be, is I'm humble enough to phone a friend. It might be seeing a specialist such as Dr. Suchkin or Goldstein or another endometriosis specialist. Or maybe it requires getting more imaging, such as an MRI, and making sure that that MRI is done at a center that actually knows how to look and evaluate for the signs of endometriosis. Most importantly, The decision for surgery is personal. Surgery is not without risk, but surgery also has the opportunity for great reward. So it's a personal decision that each patient and practitioner should have.
And is surgery necessary before trying to get pregnant or undergoing IVF?
I think for each patient, it's an individual conversation to have. I think many patients who end up having surgery regret not having it sooner. I think for many patients who wonder if they needed to have surgery because they got pregnant after, well, we don't have the time machine, but I also say we don't want to experiment with someone with luck. So it's a very personal decision, but making sure that you go to someone who's a skilled practitioner is the most important thing when making a surgical evaluation.
Dr. Goldstein, I'm not sure if we want to pass the next question to another physician or keep this with Dr. Levine.
Yeah, absolutely. I think Dr. T is on here as well now. Thank you for joining. So we have a couple patients that asked about immune antibodies. Have they been correlated with endo? Which ones? I have heard some people with endometriosis could have recurrent miscarriage due to a killer cell. What is a killer cell? Is it a proven theory? Thank you for your lecture. I know it was very detailed for some of them. So if you can sort of give it in a very early patient format, they're wanting to know more about the natural killer cells and the treatment for it you were talking about earlier. Just unmute yourself, please, Dr. T.
Okay. So there are a plethora of autoimmune diseases that are associated with endometriosis. Yeah, I think it bespeaks the fact that there's some underlying immunological mechanistic problem that may feed into both sort of pathophysiologies. But I don't think the presence of, for example, anti-thyroid antibodies or anti-Rho, anti-LA antibodies have any specific indication that you're going to be worse in terms of your prognosis or presentation with endometriosis. I think it's more of a wake-up call that if you have a patient that presents with these other autoimmune diseases, they need to be worked up for endometriosis, potentially, if it's a silent disease. In terms of the natural killer cell antibody phenomenon, very controversial. I'm very humble about this because I think the data pool which is out there, which is I think fairly limited, but you can't deny that there's been several associative studies that suggest that in women that have recurrent miscarriages, peripheral natural blood killer cell levels are indeed associated. And mechanisms of, treatments that actually bring down the natural killer cell activity have been shown to ameliorate the miscarriage rate. So I try to maintain a treatment profile that I think is safe and gentle. And towards that end, I favor corticosteroids and intralipid.
Great, thank you. Okay. Let's see. Maybe Dr. Sutchkin, you want to come in for this one real quick? We have what causes implantation pain throughout the pregnancy? Not just implantation cramping, but in miscarriage. Is this placental malformation? Every pregnancy this patient carried had caused excruciating pain. She's asking about pain in pregnancy.
You're asking me the hardest question, so let me reposition myself in my house.
Okay.
Look, as I'm going to generalize the answer because, as you know, all the speakers, the way they talked about endometriosis, you can tell everybody has their own opinion, as if they're holding the elephant from one leg and they have their own opinion about it. And that also applies to me too. So that's what endometriosis is. But you never heard, or rarely, like that Tortellio subject is really about inflammation. The inflammation, many of the time, the inflammation aspect of endometriosis is ignored. And that's what we go after surgery. We remove the inflammatory tissue and preserve the ovary. Many times, many times, the peritoneal component of endometriosis is so solidly, overwhelmingly present physically, objectively, and removing that is really the removing that is inflammation. It's a fibrosis. It's the disease of fibrosis really is more than gland and stroma we define. It's inflammatory fibrosis that covers the whole peritoneum. That's the source of pain. And that it interferes with possibly with a lot of issues that we discussed today. So the role of surgery is removing that. And the course of pregnancy is obviously complicated more. I would assume what I read and what I hear from patients also, the symptoms of endometriosis is alive during pregnancy if there's a peritoneal disease and scarring, especially advanced stages due to stretching of the retroperitoneal posterior pelvis. It is written that these pregnancies are eventful, early miscarriages, premature births, certainly deep placentation with previa accreta are described. So the bottom line is early awareness, early diagnosis, detection of the disease, timely intervention through education and joint decision making with the fertility specialist is the key to probably prevent the adverse effects of the disease. Excision surgery is important, not for everyone. That's personal decision. Patient has to make that decision themselves. Thank you.
I think anyone could take this question if they like. Can hormonal suppression help with infertility without removing the endo by surgery, or can BCP suppression worsen infertility if used prolonged?
Dr. Singer, you want to take that one?
Sure, I'm happy to take that one. So there's always been a debate whether or not you need to do surgery before you do IVF, especially before you do a frozen embryo transfer. There's been some studies that showed that suppression with Lupron prior to frozen embryo transfer has increased the implantation rate. So the solution is not always surgery, but we know that patients that present with stage 3, stage 4 endometriosis, especially if they have adenomyosis and endometriomas, will benefit from surgery prior to a transfer. The alternative is to do the retrieval to get the embryos in the setting of an IVF and then suppress the ovary, suppress the uterus with Lupron for 2 to 3 months, and then do a transfer. But that's only in the setting of IVF. There's always a debate whether or not IVF is the right treatment. There's a lot of young patients that suffer from endometriosis that can benefit from just ovulation induction with letrozole, which works by lowering the estrogen level, which in fact, indirectly alluding to some suppression, right, of the endometriosis lesion. So I think that yes, there is definitely some methods and some techniques to suppress the endometriosis as a part of the process of fertility treatment. And it's not always that a patient will have to go through surgery before she can conceive. I hope that answers the question.
Yes, and just a follow-up to that, you don't feel that necessarily birth control suppression.
Patients are concerned and worried if they've been on it for many years for their endo symptoms, would that cause trouble with them getting pregnant? I know what I tell them in our own practice is that definitely can suppress their ovaries for up to a year after coming off of the pill, but your thoughts as well.
So OCPs or birth control pills have been very successful in suppressing development of cysts, and just by virtue of suppressing ovulation, it reduces the risk of a residual cyst. Yes, there have been some studies that show that the AMH, which is one of the markers that we use to assess ovarian reserve, has been lower while patients have been on birth control pills for a long time. But I'm not a big believer that birth control pills are a culprit in the fertility. In fact, they're helping us manage the patient who suffers from infertility. And as I'm sure other people on this panel will agree, we incorporate birth control pills more frequently with patients with endometriosis than with any other type of patient because they're helping us suppressing cysts, they're helping us getting back to the starting point after an egg retrieval, and they're helping us not having to deal with a large endometrioma during an IVF cycle. So those of you who are concerned of being on birth control pills for endometriosis, rest assured that the fertility specialists, definitely on this panel, know how to tackle that and get you to where you need to be. And don't be afraid of taking birth control pills, because it may save you surgery down the line if you're really suffering from an advanced disease.
Thank you. Let's see, Dr. Akte, thanks for joining. We have a question from a patient. Would fertility preserving surgeries still be linked to decreasing the ovarian reserve, or is decrease of ovarian reserve only relevant
when endometriosis on ovaries, endometriomas are present?
I think with the precise surgery you're always doing a good job, I'm sure, but it's whenever the surgery is on and around the ovary, there's always a risk of destroying the primordial follicles, which make up the ovarian reserve, regardless of how delicate the surgery is, through scarring and stripping and etc. There's always so I think ovarian surgery is always the last resort if you are concerned about ovarian reserve, if that was the question.
Yes, thank you so much.
Well,
and maybe Dr. Akte as a follow-up, are you still there?
yes, I am. It's
Okay.
it's a real me here. Okay.
Yeah. Okay. Also, you talked a little bit in your presentation as well about ovarian surgery
Or ovarian preservation, removing part of the tissue at the time of surgery. If the patient is having, for instance, an oophorectomy or ovarian removal due to very severe stage disease, I know it's quite difficult to coordinate, but you are hopeful that sometime you are able to preserve some of that ovarian tissue. I know with the endometriomas, there can already be disease damage, and it may be harder for you to use that later, but I have had patients ask if they can preserve that at the time of surgery. Sort of, can you give us a two seconds about that?
Sure. This is, again, a risks and benefits assessment, right? If a patient is only having cystectomy and if we also take a piece of tissue to preserve it, I mean, if she's not going to develop further disease and compromise her tissue, are we helping her? But at the same time, if there's going to be radical surgery and she's going to be losing an entire reserve or close to it, or you suspect that might happen, it might be worth saving that tissue. And the amount is important. If you take too little, it may not be functional enough for getting ovarian function for fertility purposes. However, in the long run, there are efforts going on, including in my research laboratory at Yale, and we have some strides in that, growing follicles from small pieces of ovarian tissue, which is not yet practical, but there may be developments on that. So that would be a judgment. And obviously, if you're planning a surgery like that, that can be arranged. And what we do in cases like that is come in the OR and assess the tissue and separate the healthy from unhealthy, not just for endometriosis, for example, borderline ovarian tumors and others, and make its judgment. But sometimes even the smallest tissue could be saved with the idea that in the future, we might be able to develop in vitro primordial follicle growth strategies. So I think that should be always a part of the discussion.
Nice, thank you.
Thank you.
Okay.
Dr. Levine, there's a question about, is there a different IVF regimen for someone with endometriosis versus someone without? If you want, we're happy to have all of your expertise here. If you each want to kind of give a 2-second on what you would do differently,
That's welcome. Dr. Levine, do you want to start?
Sure. So, we get this question quite often, which is they have the devastating diagnosis of endometriosis, and now there's a great concern of what is the right protocol. And they start seeing, some of the great experts that are on this panel here, they kind of shop around from doctor to doctor, say, who has the secret recipe? The truth is there's no protocol that any center is going to have or any individual physician is going to offer that's going to be endometriosis specific. More importantly, I think it's understanding the progression of disease and understanding the disease that we're treating. In our philosophy here at CCRM and the 11 clinics that we have around the United States, we favor doing frozen embryo transfers, which means that we do a retrieval, we grow embryos in a lab, we genetically test them, and then we freeze them. We believe that for those patients that have endometriosis, this offers them the greatest chance of success because most importantly, we break that cycle. We break that cycle between the stimulation. We allow for adequate suppression, as both Dr. T and Dr. Singer both said before. And once they're adequately suppressed and they're back in a state where we don't think any endometriosis is at bay or is going to flare, then we could put back an embryo in a controlled manner. With that said, when patients who have moderate or severe disease, of course, we use letrozole, as Dr. Singer had hinted at before. Letrozole is a medication that helps lower down the serum estrogen levels, helps us hold estrogen levels a little bit lower, because the thought is, if estrogen is the oxygen that makes the fire rage, how do we keep that oxygen a little bit lower? With that said, though, if you can break it into two parts, and you break the first part of the cycle into making the best embryos possible, and the second part of the cycle to making the best environment possible, I think that's the best approach for endometriosis, not a certain medical regimen.
Perfect, thanks. Dr. Singer?
Yeah, I agree with Brian, and I would add that when you do the frozen embryo transfer after the retrieval and after breaking that process into two separate events, I would lean towards using a natural frozen cycle approach rather than a program cycle, which we tend to use in a non-endometriosis patient. What it means is essentially that instead of giving the patient estrogen to build up the lining to allow the embryo the best chances of implantation, is we essentially watch the patient's natural cycle. And once the patient is recruiting a follicle on her own, which secretes the degree of estrogen, we essentially piggyback on that. And once we see ovulation, we detect it with a daily blood test and ultrasound. 5 days later, do a transfer without any intervention with estrogen, and just supplement with progesterone, and that will be it.
Great, thank you. Dr. T, any thoughts?
No, I agree with what's been said. There's no such thing as a specific endometriosis protocol, but I think the adjunctive use of letrozole during the stimulation certainly is smart for its potential in situ effects. And just piggybacking off what Dr. Singer had mentioned, very often I might consider letrozole as part of the actual transfer protocol rather than do a completely natural transfer protocol. A little bit of letrozole for the stimulation with a trigger shot, and then followed by a transfer about a week later.
Agreed.
I agree with Dr. T as well. I'll share, recently we've been using Orilissa for certain patients as opposed to using Depo-Lupron. We've been using a combination of birth control pills and Orilissa. Orilissa is a oral GnRH antagonist, and really doesn't have a flare if you do the birth control pill. So it's really an antagonist the whole time with a very short half-life. And we've been using this because we noticed that some patients really can't tolerate the Depo-Lupron side effects if you suppress them for 1 or 2 months. Mm-hmm. What we noticed was that the benefit is, and again, we're still collecting cases on this, but if you use Orilissa and birth control pills in combination, you can do the ovulation induction technique that Dr. T just referenced for doing your embryo transfer. As opposed to if you do Depo-Lupron for 2 months, sometimes they're so suppressed, it's hard to get ovulation induction to occur with using that letrozole trick that he mentioned. The nice thing also about Dr. T's approach, where he said using letrozole as your adjuvant to help, grow the follicle and basically hijack it to then put an embryo back, is that by using an HCG trigger, you also rescue that corpus luteum, and in theory, you support that corpus luteum so that patient makes the most progesterone possible, so you can actually follow what Dr. Singer said and just put back a little bit of hopefully vaginal progesterone and try to limit the amount of shots that people need. I think what you're hearing is all three of us integrate these approaches, and we use unique approaches for these really unique class of patients.
Nice, thank you. And I think this is a great question. And whoever really can answer it. When would you advise someone to stop IVF? Is there a number of times it should be tried, or does it depend on the eggs retrieved in our embryos? I actually had patients in our own practice. We had someone that came and they had sort of a gene line mutation, not BRCA. It was another germline mutation that they were worried about, breast cancer in the family history. And so they saw an NYU geneticist that recommend only 5 stimulation protocols or 5 egg retrievals. And so I haven't personally, or as a physician, I haven't heard too much talk about that. It was a long time ago. We used to talk about it in residency, how many rounds and when you should move to donor and other things. But curious if any of you, refer to geneticists normally or have sort of a limit you do with patients, or what you would say, what is too much and long-term, cancer risks of that, even though, we don't have a lot of strong studies. What do you sort of approach with your own patients?
I'll go last because I got to go first on the last one.
Okay, no problem. Dr. Singer, you want to start this one?
I'll start first. So, as I mentioned in my lecture regarding donor egg and the gestational care and the use of third party, I don't think there's any specific number that pertains to every patient. Obviously, it depends on the patient's history, the severity of the disease, the patient's age, quite frankly, when she's starting the fertility treatment, prior failure, if there's been any pregnancy losses along the way. And what we assess in an IVF setting is several variables. First, whether or not the patient had reached a retrieval, whether or not she has gotten eggs during the retrieval. How did the eggs look in the dish on the day of the retrieval? What was the fertilization 24 hours later? And what was the blastulation, which essentially means how did the embryos look along the way from day 0 to day 5, 6, and 7? And those are markers that tells us, are we dealing with eggs that could potentially make a euploid blastocyst? And we have a very honest approach with the patient, and we share with them every step of the way what exactly are the findings. And those findings are very telling. So if a patient had 3 retrievals and in none of those retrievals she had made any blastocyst, she had made blastocysts and all of them are chromosomally abnormal and morphologically are poor in quality, that's when we're going to start discussing an egg donation. Some patient, because of financial reason, after 1 IVF cycles that resulted in no blasts or no embryos, will have to discuss egg donation because that will give them 50 or 60% chance of a viable pregnancy compared to maybe 5 or 10%. So I think it's a personal decision. It's a discussion that the patient should make with her partner if there is a partner, along with the guidance from the physician. If the patient went through IVF and has really not liking the stimulation protocol and the bloatingness and was not really a happy camper during that cycle, it may be just 1 cycle and you move on to an egg donation rather than go through 5 or 6 cycles. But I've had patients who's done 6 and 7 and 8 cycles because for them, even 5% means the world. And I think it comes down to a personal decision and what we see in the lab.
Dr. T?
Yeah, it's a very tough decision to make. I mean, we got into this business to get couples pregnant. Mm-hmm. So it's very hard to tell somebody you think they've reached the point where they need to move onward. Mm-hmm. I mean, there have been some studies that suggest that the cumulative pregnancy rate increases up to about 6 cycles. So theoretically, it's not unreasonable in women that have, I think, a fairly decent egg reserve and the ability to make some embryos to go up to 6 cycles. But what Dr. Singer was saying is absolutely true. Every person is uniquely different in their tolerance psychologically, physically, financially as to what they can accomplish. I like to reconnoiter with the patients after every IVF cycle and say, this is what I was expecting. This is what we achieved. This is what I think we might be able to achieve with another cycle if we were to try something potentially different. And jointly, usually that decision is made. I like to see progress being made. If I genuinely think that I'm not making progress with, using everything in my armamentarium to try to get them pregnant, then we'll have that tough decision and decide to move on. Could be after 1 cycle, could be after 6.
I want to make some points, if I can, for the record, for everybody's, I'm sure they're interested. There are 3 issues in endometriosis surgery that we pay attention. One is the whole technique involves, obviously, when you remove a cyst, it has to be so precise, so delicate. And it does count. The experience is very important. You need to bring some degree of contrast. We use blue dye, heavy blue dye, to get rid of the redness and yellow. And so reflection is, so you can really identify the cyst to the limit of very membranous elements that you strip with the, so you have to be so precise with that. So seeing is important. Movements are important. The technique is very, it's like playing the violin there. So most importantly though, after you remove the cyst, there should be no cautery. There is bleeding, certainly. But if you start doing monopolar or even bipolar, you're starting cooking things there in the background. It has a 1 centimeter distribution rate spread around. So the best thing is use fine suturing. Fine suturing like Victor Gomel, microsurgical procedures, you bring the ovary back. We see disastrous ovaries after surgery, split apart like birds, dead with bird's wing. One is attached to the bowel, the other to the ureter, attached to the pelvic sidewall, please. So so we reconstruct with fine suturing, no cautery at all, absolute reconstruction, plastic surgery. Then we suspend the ovaries after surgery, 24 hours minimum. Patient stays in the hospital because we do a lot of a lot of extra ovarian inflammatory fibrosis removal. So pelvic sidewall is basically clean to its anatomical delicacy of retroperitoneum. And then the third thing I think is important is there is parenchymal endometriosis that you really very little written about. It's a big surgical challenge. The endometriosis beyond the cyst is like a deeply invasive endometriosis of the ovary. So the rest of the parenchyma is involved. I think those are the cases difficult to really guess. As soon as you see resistance, sometimes we have to stop. You know that when you rip that, you're going to do literally real oophorectomy, leaving something behind. It doesn't count. So in those cases, I guess maybe just leaving if it's not separating, surgeon has to stop and maybe use some degree of caution. There's maybe one ovary, then they can go stimulation. There could be another surgery maybe later. But I think getting the endometrioma cyst out, devolume the ovary, and preparing is for the best for the stimulation after is the best approach. So the patient has to be consulted all these aspects of the varying degrees that can affect the outcome of the surgery. I would just want to make these remarks for the record. That's all. Thank you.
Right. We have one more patient question. Let me see. We have several, but I'm trying to keep them pertinent to today. I have been recently diagnosed with being allergic to my own estrogen. Every time they have stimulation or implant, they have numbness, tachycardia, trouble breathing. And they're wondering if any of you have ever seen this before, and is it going to be possible for them to get pregnant? A loaded question, but anybody that it's up for grabs.
Allergic to her own estrogen?
Yeah, I don't think I've seen that. So, when a patient has a dominant follicle, usually mid-cycle, around cycle day 13, 14, and that ovary will secrete about 200 to 350 picogram per ml of estrogen. So that's the patient's own estrogen. What I think that patient is alluding to is when she's being stimulated, her estrogen is going up, and that high level of estrogen may be causing her to have some kind of symptoms that may mimic allergic reaction. If the patient had gotten her period in her teens and never had an allergic reaction every time she was ovulating, that means she's not allergic to her own estrogen. She's probably not tolerating high level of estrogen. And there's ways to tackle that. So doing a letrozole protocol or Femara will reduce your own estrogen, and you can still recruit 2 or 3 follicles in that setting. And you can do a natural cycle IVF in rare occasions when a certain level of estrogen causes the patient to become tachycardic. But I would encourage you to see an allergist and try to see if there's anything else that's going on. And I've never heard of a patient being allergic to her own estrogen. So not sure where exactly that diagnosis came from.
Thank you. Yeah.
Brian, Drew, did you see it before?
Allergy to estrogen?
Yeah.
I've never heard of the phenomenon, but I would tend to agree with you in that it may be relating to the medications that she's taking or the symptoms that she's getting from being close to hyperstimulated. The other possibility, I mean, if there was some sort of genuine allergy, which I doubt, or she is having problems with medication, she can actually have an IVM or in vitro maturation procedure where immature eggs are retrieved. She basically needs to take almost no stimulation medication whatsoever. And in a very specialized and skilled laboratory, they can be matured into M2s.
Let's see, I have one other, let's see. Why can women only get natural killer cell testing when they were trying to get pregnant? I've not been able to get natural killer testing from my gynecologist, even though it's highly associated with endometriosis. So you can take that one, Dr. T. And I would just say, as an endometriosis specialist and surgeon, we don't test for, even in our practice, obviously, for natural killer cell elevation across the board in patients. To our awareness, even in our population, which is 98% endometriosis patients in our practice, by doing that test alone, the results will be quite varied. Some will have completely normal natural killer cells, and it does not mean that they don't have endometriosis. They may even have severe endometriosis. And so to my knowledge, and you can back this up, but for us, it's not an across the board. There's no perfect, unfortunately, diagnosis of endometriosis without pathologic and surgical diagnosis, except for if we see a very obviously endometrioma on imaging, severe adenomyosis, that we have a very, very high index of suspicion. But even those, sometimes you can get a strange granulosa ovarian mass or something that looks just like an endometrioma on imaging, and then when you get into surgery, it's not. And so I would say to these patients that we don't run these things across the board. We are, advocating more for what we were talking about earlier, Receptiva or BCL6, which I know many of you offer in your practices. But to my knowledge, if I run this test, if Dr. Session and I run this on every single patient we have, they may not, and it's not an across the board diagnostic marker for our patients.
Yeah, absolutely. I mean, it's not like anti-thyroid antibodies, where if you have anti-thyroid antibodies, you know that you have some sort of autoimmune thyroiditis present. It's too non-specific a marker for you to really know what you have and what to do. I think the role that it has essentially is if you're already somebody with a clinical history, you have a clinical history of unexplained infertility or clinical history of recurrent miscarriage, then you start to think of potentially testing for this, because you could presume that with these findings and everything else excluded, you're going to glean some positive benefit. I like to do these tests primarily in women who have basically done IVF and have chromosomally normal embryos, and you're putting back chromosomally normal embryos, and you're quoting them about roughly 60% live birth rate with a chromosomally normal embryo. You've put back 3, they're not getting pregnant or they're miscarrying every time. Statistically speaking, something is not right. And that's when you have to start looking outside the box. Maybe start looking for Receptiva and BCL6 at this point, if you have no clinical indication that they have endometriosis. Or maybe at this point you do look for natural killer cell activity. But it is not useful, it is not so useful a test such that a patient walking into your office, for example, would, I think, be benefited by getting this test done.
Right, thank you. Dr. Levine, I think this is a great one for you. And we have several patients that asked about when they should freeze their eggs. And you can take this one. I always tell them if they're career tracked, like doing a lot of school, if they're dating in Manhattan, I have lots of rules I tell them, but many times I think that the technology is so good now that, for women in their 20s, even with and without endometriosis, it's a great option, something that they can do, forward thinking for the future. But do you want to just highlight on that as well?
Sure. So, when we initially thought about opening our clinic, we thought egg freezing would be maybe 5% of our volume. And would be lucky to see a handful of patients a month who'd even, ask us about it. Well, 7 years later, we noticed that it's probably a third of our volume because everyone is talking about how do you protect and preserve your fertility if you're a woman, and the only way to do it is through egg freezing. With that said, egg freezing is not a requirement for every woman, and it should be viewed as one. It should be viewed as an option. It's a conversation that you have with your OBGYN and a conversation that you have with your fertility doctor. If people are fortunate enough to have an employee benefit, so in New York State, where I think almost all of us on here practice, and there is a New York State mandate, many employers have followed suit by offering an egg freezing option and benefit to their employees, and that's incredible. Because it's the only thing someone can do to stop the clock. It's not without risk. It does require 2 weeks of medication. You do have to find 2 weeks of a good time in your life to do this when you can really commit to it. And it is a commitment. It also doesn't mean that's how you're going to reproduce. And it's really important for people to understand that when you freeze your eggs, it doesn't mean you're committing yourself to IVF. It just means that if you're going to use your frozen eggs in the future, they must be used through IVF. So understand what is involved with the later stages of egg freezing. Lastly, what I always share with people is more often than not, people are not going to use their eggs, right? Fertility doctors have been around really for only, call it since 1979, 1980, from Louise Brown, the first baby that was born from IVF. We've been guiding people along the way for a long time. Egg freezing has only been permissible in this country for 10 years. And so egg freezing is not the be all end all, but it might be the way that you have kid number 2. And it might be the way you have kid number 3. And it might be the way that you actually get to protect your fertility, especially if you end up with a situation where you have a progressive disease such as endometriosis. So it's a personal decision. We discourage few, we encourage many, but it's always about a partnership between the patient and the provider.
Perfect. Thank you. I know it's 1:29 and we're trying to get everything wrapped up. We did have, I think, one great question about why must endometriosis patients wait for better testing until they want to get pregnant or pay to go to private fertility specialists? Why are normal gynecologists not testing for these advanced issues in endometriosis patients when patients are younger and have higher chances of pregnancy? I think it's a great question. We spend a lot of time in our new patient consults, as Dr. Sechkin is here. We spend over probably an hour with them on their new patient visit. And a lot of it is, why didn't my gynecologist tell me this when I was in my 20s? Or why didn't someone look at this or see this? Or why didn't someone tell me about these cysts early? And a lot of what we explain to patients too is that they're often in for a quick insurance pap smear and wellness exam. And what I like to tell them is that if they're only really having the cervix checked and the pap smear performed, and no one's really going through questions with them on pain and are they having a miscarriage or are things happening in their fertility life? Are they having painful intercourse and kind of asking these questions? Then a lot of times this disease is missed. And checking the cervix with the pap is really just like buying a house and only looking at the front door paint and not going in and walking through the entire house. And for us with the pelvis, we always think of it that way. So Dr. Sechkin, do you want to answer that one too? Did you hear the question?
Was it a question? I was listening to you. I didn't see a question there. There's a comment.
It's a very long question about why patients with endometriosis must wait to see a fertility specialist to have this testing done. And I would say it's not necessarily true. You can get an anti-Mullerian hormone test done with your primary OBGYN, with an endo specialist, with a fertility doctor as well. But they're asking why some of these advanced issues aren't checked when patients are younger and they have a higher chance of pregnancy.
I think endometriosis is the last thing before way
after fertility issue comes to the question. So I'm not sure how routine, I really forgot how in my training there was no AMA. So I don't know how this thing is being practiced in regular gynecologic office. But when I'm sure when they go when there's a fertility issue, that's being checked. Listen, the idea is the endo patients in general, when we see these patients, the story is usually same. These patients' symptoms start from the get-go. 80% of the symptoms are coming from the menarche on, and the stories are almost similar. Delay, IBS, this diet, that diet, never there's an endo. Obviously, when it's fertility, you don't want to see delay in fertility group. They're already in certain age, past 30, maybe 35, multiple failures. I regret to see patients who are coming to me by themselves for thinking that they have endo. In fact, they have advanced endo, serious peritoneal endo, and they are 40 now. And I've seen patients with 15 transfers, we have seen so many of them. So these things do happen in that world, but I am very appreciative that a group of specialists like you are sensitive to this. The delay and the timing of the interference is very important on our behalf because we guide the patients. Brian, you want to comment on something?
Yeah, I was going to say the current state of reproductive care, unfortunately, is focused on the 3 Ps: the pill, the PAP, and a pat on the back to get the patient out the door, because many of the well woman visits are about volume. All of us who are on this panel would never think of seeing a patient and performing a physical without saying that our physical is limited without an ultrasound or without doing a bimanual exam. This skill set, unfortunately, is lost. This skill set is not being used at the general OBGYN's office. And as a patient, if you want to advocate for yourself and advocate for your friends, you can do one of 2 things. One is you could say to the doctor, can I have a baseline ultrasound? I've never had one, or I haven't had one in a year. No doctor will say to you, no, you can't have an ultrasound, because it's the one way that we get to look past the front door, as you adequately said before and beautifully said, Carly. The second is, there are so many amazing resources that you can find online. If you find that you're not getting a good answer from your OBGYN, that's fine. But you can move to a telehealth solution. There's a million companies out there. There are great ones like Maven or Tia or any of these other online platforms. You can go online, you can talk to a doctor, and you can say, these are my symptoms. Are these normal, abnormal? And as Dr. Suchkin said before, if you start telling someone you're having pain with intercourse and pain with bowel movements, and you feel like your bladder's on fire and it's just not right, I bet you someone's going to help you connect those dots and get you to the right place. So unfortunately, advocate for yourself is the best advice I can give you. But don't think that you just have to stop because that's what your doctor stopped with. It might just be the way that their practice is.
Well said.
Perfect. We have, obviously there's more and more questions, but I think a lot of them we can actually save Dr. Suchkin for next weekend, have a lot to do with pain and endometriosis, bowel symptoms, things like that. So I think we'll get into this more as this conference goes on. Thank you so much, all of you, for coming and for staying on and for re-recording and being a part of all these Zoom technical issues. We really appreciate it.
And thank you. We're going to have next week, we're going to do the peritoneal endometriosis. In my opinion, the endometriosis gets bad rep because of peritoneal endo, because there is no test and it's the only patient that complains about it and the physicians may be aware of it. So there is no imaging. Endometriosis clinically for specialists. We're going to cover that in all extensiveness with Dr. Dan Martin. The following week, we're going to do deep debilitating disease, deeply infiltrating disease of the bowel, bladder, all the way to thoracic, and will be covered in our last weekend, which is the medical conference with world-class surgeons and commentators around the world. Thank you again, Dr. Ghostin, fantastic job. I appreciate it. Thank you, Diane. Thank you, Endometriosis Foundation team. I'm grateful that you all joined, Brian, Dr. T. Appreciate it. Thank you.
Pleasure.